Good morning. Good morning to one and all. We are all gathered here today for forenoon session on second day of Epicon 21-22 Confluence of Health Sciences. A very hearty welcome to all of you. It's my immense pleasure to be here today, and I hope that we all will have a great session ahead. Starting with the session, the first event for the morning is free paper presentation, and the judge for that is Dr. A.K. Pandey, sir. We welcome you, sir. As we all are very well aware that this conference is being held in hybrid mode, so some of our eminent speakers are present here with us physically, and some will join us through online mode. Before starting the event, I must notify that all the speakers have 10 minutes to them, and they can have 8 minutes of talk followed by 2 minutes for questions. And please keep the questions limited to 3 to 4. Now starting with the event, our first speaker is Dr. Naga Lakshmi V. Her topic for the talk is platelet volume indices in gestational hypertension and observational study. Ma'am, you can please continue.
Dr. Nagalakshmi, please
Yes,
share your
yes,
screen.
yes, yes, sir. Ma'am, is my PPT is visible?
No, ma'am, not right now.
Ma'am, is my PPT is visible, please?
Just wait a second, ma'am. We are checking it.
Anyone who is online can check whether it is visible to them.
Sir, it's visible for me. Will you please confirm, please?
Ma'am, sorry for the delay, but please wait.
Yeah, yeah.
Ma'am, you have logged in from two devices. So please log out from first and only log in from one device.
Okay, okay, sir. 1 second. So now I have logged out from my second device.
Ma'am, please refresh the computer or PC.
I'm doing from my mobile, ma'am.
Acha, okay.
1 second. I'll just keep, means share it again.
Yeah, sure.
Is it visible now, ma'am?
मैम आपकी वीडियो ऑन नहीं है
Okay, but is my PPT is visible, ma'am?
there it is showing.
So can I share it to your email ID, any one of yours, which you can display there?
उसको कनेक्ट नहीं कर सकते क्या? उसका वो लैपटॉप कनेक्ट कर दीजिए ना. उसमें प्रॉब्लम है ना, तो इसको कनेक्ट कर दीजिए आप प्रोजेक्ट से. हाँ, प्रोजेक्टर से कनेक्ट कर. क्योंकि हम लोगों ने कुछ कोई चेकिंग नहीं की थी. नहीं सुबह चेकिंग नहीं हुई थी मतलब. मैं वही कह रहा हूँ सर, नेक्स्ट स्पीकर को बोल दें तब तक. यहीं से है सर. वो तो उनकी शेयर हो रही है यहाँ पे, लेकिन ये इनकी जो कनेक्शन है जिससे.
Ma'am, can I share my PPT and you can display there?
श्योर मैम. मेल आईडी आपको.
Yes. You, if you tell me, I'll immediately share now. Tell me, ma'am.
Okay, we are sharing our mail ID on Zoom chat. You can mail us there.
Yes.
उनको जो बोलेगा
यार उनकी देखो स्क्रीन जूम मीटिंग में शेयर हो रही है, यहाँ पे आप नहीं शेयर कर पा रहे हो. वो तो ठीक. हाँ, अब हो गया ना. इनको नहीं है, इनको बता दो. टेल देम कि यू कैन शेयर नाउ.
She doesn't need to send it now. Ma'am,
Yes, tell me, ma'am.
ma'am, you need not to share it or send it through the mail. We can see now.
Okay.
So क्या चाहिए? हुआ?
Ma'am, can you see it now?
Yes, ma'am. We can see it now.
Okay. So once you tell me, I'll start, ma'am.
Sure, ma'am. Sure. Ma'am, you can start now, please.
Yeah. A very good morning, everyone. This is Dr. Nagalakshmi. I'm a professor in the Department of Physiology, SDM College of Medical Sciences and Hospital, Sri Dharmasthala Manjunatheshwara University, Dharwad. I'll be presenting my topic on platelet volume indices amongst gestational hypertension. Coming to the background of the study, nowadays in the pregnancy-induced hypertension is becoming very common. And an average of around 10% of the pregnancies, females, are landing up in developing pregnancy-induced hypertension. And the problem is this PAH, that is hypertension during pregnancy, can cause a significant maternal as well as perinatal various morbidity as well as mortality, like premature birth or ending up in severe preeclampsia. So the American College of Obstetrician and Gynecologists have classified this hypertension in pregnancy as 4 types, like gestational hypertension, which we can say that pregnant female having systolic BP of more than 140 and diastolic BP of more than 90 millimeters of mercury, which is develops after 20 weeks of gestation. But if the similar value exists in a pregnant female before 20 weeks, they call it as chronic hypertension. And if a pregnant female develops SBP of more than 160 and DBP of more than 90, along with proteinuria, it is classified as preeclampsia. And if this develops in a chronic hypertension female, we call it as eclamptic superimposed on chronic hypertension. What we are studying in our thing is only gestational hypertension. And we all know that pregnancy is in a physiological state where there is hypercoagulable state exists. And it is the platelets or thrombocytes, which are the type of blood cells which plays very important role in various thromboembolic condition. So we thought of studying various platelet volume indices amongst gestational hypertension. So coming to our objectives of a study, so we wanted to record the systolic blood pressure and diastolic blood pressure to determine the hypertensives as well as to have normotensives as controls, and also recording various platelet volume indices like mean platelet volume, platelet distribution width, platelet lot cell ratio, and platelet crit amongst hypertensives as well as normotensives, and to compare them, and also to correlate the severity of BP values with this various platelet volume indices. So coming to the methodology of a study, this was a cross-sectional study which was done an observational study, and we had case and controls as well. This was conducted in the Department of Obstetrics and Gynecology along with Pathology Department. We obtained institutional ethical clearance before we started our study, and the study duration was planned for 6 months from June to December 2021. Our accessible population was all the pregnant females who were in third trimester only and who were attending our OBG OPDs, and our target population was those who were in the age group of 25 to 40 years and who were diagnosed as hypertension by obstetricians. We included them as cases, and we included only gestational hypertension cases, and we also had normotensives who were having SBP between 100 to 140 and DBP between 60 to 90 mmHg as normotensives as controls of a study. But we excluded who had gestational diabetes and who were diagnosed with various hematological disorders, especially anemia. We excluded them from our study. And our sample size was 60 hypertensives and 60 normotensives. This sample size was decided based on the other references as well as keeping the study duration in mind. Coming to our study protocol, estimation of blood pressure. So the blood pressure was recorded using the standard method, that is using the mercury sphygmomanometer by both palpatory as well as auscultatory methods. So usually in a pregnant female's BP will be recorded after a lying down of 10 minutes. We ask them to sit with the back supported, and then we record the blood pressure. So who had a SBP of more than 140 and DBP more than 90, we included them as gestational hypertensives, and who had normal SBP and DBP values, we were taken them as normotensives and included in our study as controls. We recorded various platelet volume indices like mean platelet volumes, platelet distribution widths, platelet lot cell ratio, and platelet crit. So these values we took it from pathology laboratories, and they were calculating all this using Sysmex automated flow meter, using the principles of impedance and optical light scatter. So once we recorded all the data, So we statistically analyzed them using SPSS software 20. We used unpaid t-test to as well as Pearson's correlation to calculate means to get the variables done. So this is a diagram where I'm showing few of the demographical characteristics of the case as well as controls. The above one is a pie chart where we can see that among us the 60 hypertensives, the majority we had were who were in second gravida, which an average of 38. And among us 60, 21 were primary and only one was in third gravida. And the bar diagram, we can see clearly that there was a statistically significant increase in both systolic as well as diastolic blood pressure among us hypertensives when compared to normotensives, where the average value of SBP was around 151 millimeters of mercury and DBP it was around 90.86 in hypertensives. This is a table which is showing the platelet volume indices between gestational hypertensive as well as normotensives. What we can see is there was a significant decrease in the platelet count in gestational hypertension when compared to normotension, and mean platelet volume, platelet distribution width, as well as platelet large cell ratio was higher in gestational hypertension when compared to normotensives, but we didn't obtain any statistically significant difference. Again, in platelet crit, the platelet crit was actually reduced in gestational hypertension when compared to normotensives, but
Ma'am,
in none
sorry to
of the
interrupt.
yes,
Sorry to interrupt, but your time only
okay,
limits to 8 minutes, and you have only 1 minute left.
okay. Thank you, ma'am. I'm finished. This diagram, which is showing correlation, and we didn't obtain any significant correlation with the BP values with other platelet indices. So coming to the discussion and conclusion, the platelets, which plays very important role as we all know in hemostasis as well as coagulation, and the increased mean platelet volume in gestational hypertension could be because of endothelial dysfunction, and increase in platelet distribution width is again because of increased platelet activation, and platelet large cell ratio increase in gestational hypertension could be because of bone marrow activation, and because of reduced platelet count, usually the platelet crit will be reduced in gestational hypertension. So one of the definitely limitation of a study is we could have planned for follow-up studies. This study opens the scope for further research. When we did review of literature, we could see that there is no standard cutoff value for all these platelet volume indices, and platelets as such is not much studied among us hypertensives, and this can be definitely planned. So conclusion of a study, platelet volume indices are definitely altered in gestational hypertension. So thank you so much. I would like to extend my thanks for Apicon organizers who gave me this immense chance to present my article, my thing in this conference. Thank you so much, one and all. Thank you.
Thank you.
Good morning, Dr. Raghavi. It was a good presentation and good observation. My only question is, do you try to understand or find out what could be the physiological basis for alteration in platelet volume indices?
Sir, sir, I'm not, sir, please, can you be little louder, sir? I didn't hear your question.
No, just I would like to know that did you try to find out the alteration in platelet volume indices during gestation? I mean, what are the physiological basis? Or because as observation it is good, you find some interesting observation, and that may be applied for further research as well as for implication. But we would like to, understand if there is any physiological basis we can establish.
Yes, sir, definitely. Actually, when I read lot of literatures, What literature says that because of increased platelet usage in normal pregnancy, other than hypertension, even any pregnant female, because of increased platelet usage, because of the uteroplacental circulation, as well as the pregnancy itself causes a strain on vascular endothelium. So this is happening physiologically. Because of these two things, there is decreased platelet count as such in case of normal pregnancy, and to compensate that, there is an increase in mean platelet volume. And this increased mean platelet volume is because of, they say, the strain on the vascular endothelium. And whenever there is endothelium straining, this generally activates the platelets, and platelets will try to morphologically alter, becoming pseudopods extension, and they become larger. I guess that this is what happens whenever there is collagen exposure with any platelets. And physiologically also, the in any pregnancy, platelet count will decrease, and to compensate that, mean platelet volume will increase. But what is happening in gestational hypertension is exaggeration of that event.
Okay, thank you very much. Any one question may be permitted from virtual audience. If anyone has question, please introduce yourself and then ask the question. Okay, if there is no question, again I congratulate Dr. Naglakshmi for a very interesting observation that I think will be the clinical implication will be good for the society. Thank you very much. We will move to the next presentation. You ask whether it is online connected or not.
Thank you so much, ma'am. Now our next speaker, Dr. Navneet Kaushik. Can you hear us, sir? Dr. Navneet Kaushik. Okay. Uh, he's not with us right now. Dr. Neena Sharma. Dr. Neena Sharma, can you see us
Yes,
or
ma'am.
hear us, ma'am?
Yes, ma'am.
Okay. So now the speaker will be Dr. Neena Sharma, and she will be talking about hemophilia B. Ma'am, you can share your slides and you can start your talk.
Okay, ma'am. Good morning, judges, faculty colleagues. I'm pleased to have an opportunity to speak in APICON 2021 and present my paper. I'm Dr. Neena Sharma, Associate Professor at AIIMS, Jammu. The topic for my presentation is hemophilia B. Hemophilia B is a group of inherited blood disorders in which blood does not clot properly. Bleeding disorders are due to defect in blood vessels, the coagulation mechanisms, or the blood platelets. Blood coagulation mechanism is a process which transforms blood from a liquid into a solid and involves different clotting factors that generate fibrin fibers through extrinsic or intrinsic coagulation pathway, which along with platelet plug stops the bleeding. When coagulation factors are deficient, the blood does not clot properly and the bleeding continues. An affected individual may bleed spontaneously or for longer than a healthy person after injury or surgery. Patients with hemophilia A and hemophilia B have genetic defect in deficiency of blood clotting factors. Hemophilia is a X-linked recessive disorder that affects the males, while the females are protected by normal gene on X chromosomes. Hemophilia A is the most common genetic defect due to deficiency of factor VIII. 70% of the cases are inherited as X-linked recessive trait, and 30% of cases arise from spontaneous mutations. Hemophilia B is the second most common genetic defect due to deficiency of factor 9, also called as Christmas disease, after the name of Stephen Christmas, who had the disease. It is an X-linked recessive disorder caused in 70% of cases by mutation of factor 9 gene located on X chromosome and in 30% of the cases by spontaneous mutation. Queen Victoria was a carrier of hemophilia B caused by spontaneous mutation and passed the mutation to her son Leopold, who had hemophilia, and through her daughters to the members of royal families of Spain, Russia, and Germany. Aim and objective: a report of presentation of a case of hemophilia B. The present case report was done to demonstrate the sign and symptoms of hemophilia B, complete hematological, bleeding, and clotting tests done for the diagnosis and its treatment. Methodology: an 18-year-old male developed pain in the right leg and was unable to walk. The pain was so severe to the extent that he could not move from the bed. There was no history of trauma, fall, or injury. The symptoms began instantaneously. With these complaints, he was admitted to GMC Jammu. General physical examination revealed pallor, pulse 62 beats per minute, and hypertension. Examination of the right leg revealed tenderness in the right thigh with swelling. Investigation profile revealed hemoglobin 7 gram %, total leukocyte count 8,000 per cubic millimeter, and differential leukocyte count with neutrophil 64%, lymphocyte 25, monocyte 5, and eosinophil 2%, and platelets 2.5 lakh per microliter. Peripheral blood film showed microcytic hypochromic anemia. Ultrasonography of the right thigh showed 9.5 into 4.5 centimeter heterogeneous area in right iliopsoas, indicating right iliopsoas hematoma. The ultrasonographic report of hematoma in the iliopsoas muscle pointed towards bleeding disorder, as there was no history of injury, fall, or trauma. The platelet count was within the normal range. Other investigations conducted were prothrombin time, activated partial thromboplastin time, factor 9 levels, and factor 8 levels. The prothrombin time was 10 seconds. The normal range is between 10 to 12. Activated partial thromboplastin time 45 seconds. The normal range is 34 seconds. And factor 9 level was 20 international units. Normal level is 70 to 120. And whereas factor 8 was 80 international units, which was within the normal range. Observation: the prothrombin time explores the defect in extrinsic coagulant pathways. The prothrombin time was recorded to be normal. The activated partial thromboplastin time takes into account any effect of deficiency in intrinsic coagulation pathway. It is a screening test for disorder of intrinsic pathway, mainly factor 8, 9, contact factor, and factor 11, thus permitting the diagnosis of hemophilia. The which pointed towards the defect of intrinsic pathway. Factor 8 levels were determined, which was within the normal range, and factor 9 levels were decreased. Finally, a diagnosis of hemophilia B was made in context of increased APTT and factor 9 levels. The subject was administered replacement therapy with slow intravenous infusion of concentrate of clotting factor 9, 4,000 units on day 1 and day 2, and the dose was tapered to 2,400 units on day 3, and finally 1,800 units on day 4 and day 5. In addition to the replacement therapy with clotting factor, symptomatic treatment for pain and antifibrinolytic drugs were given, and the patient was discharged on day 6. Now, discussion. Hemophilia B is less common than hemophilia A, affecting 1 in 25 males. Sometimes a baby is born with hemophilia B when there is no family history, that is, gene may be hidden or passes to several generations of female carriers without affecting male members, or change in X chromosome is due to spontaneous mutation. The normal level of factor 9 range from factor 8 and factor 9 range from 50 to 150%, and the severity of the hemophilia depends upon the amount of clotting factor in the blood. On the basis of the amount of clotting factor in the blood, there are 3 levels of hemophilia. mild hemophilia, there is 5 to 50% of normal clotting factor in the blood. The presentation of a patient with mild hemophilia B is such that post-bleeding episode may not occur till adulthood unless an injury, surgery, or tooth extraction results in prolonged bleeding. Women with mild hemophilia presents with menorrhagia, heavy menstrual periods, and hemorrhage after childbirth. Moderate hemophilia, there is 1 to 5% of the normal clotting factor in the blood. The patients have bleeding episodes after injury or without any cause, called spontaneous bleeding episodes. In severe hemophilia, there is less than 1% of the normal
Ma'am,
clotting.
sorry to interrupt you, but you have only 2 minutes left to yourself.
Okay, ma'am. The patients have frequent spontaneous bleeding episodes, often into the joints and muscles. The mainstay of the treatment for hemophilia is replacement therapy with concentrates of clotting factor 8 for hemophilia A and clotting factor 9 for hemophilia B, given slowly intravenously. A known complication of replacement therapy is that clotting factors made from human blood can carry viruses that can cause AIDS and hepatitis. However, this can be prevented by careful screening of the blood donors, testing of donated blood products, key treatment of donated blood products, and vaccinating the people who have hemophilia for hepatitis A and B. The delay in the treatment of hemophilia can lead to damage to the joints, muscles, or other parts of the body. In addition to the replacement therapy with factors, antifibrinolytic drugs like tranexamic acid and epsilon aminocaproic acid are used to prevent the clot from breaking down. Research studies are being undertaken by researchers to correct the faulty genes that cause the hemophilia. Conclusion: a case of hemophilia B after diagnosis needs replacement therapy with slow intravenous infusion of concentrate of clotting factor 9, symptomatic treatment for pain, and antifibrinolytic drugs. The references are from different topics, and thank you.
Thank you, Dr. Neena, for
Thank you, sir.
good presentation, good observation. It's a purely clinical study, but you saw that some studies are going on to find out the faulty genetic defect, and I do agree that to find out the faulty gene and the corrective measure may be a permanent cure, but have
Okay.
you any, I mean, the reference about the genome sequencing of hemophilia B group of patients and what type of genetic defect are being observed?
So the genetic defect reported is in chromosome number 8, chromosome X, and the position, it may be 27, chromosome number 20. So the site may be so it was mentioned in the slide 27.1Q, one of the present PPTs.
In your observation, obviously slow infusion, intravenous infusion of the factor is the only treatment available right now. So
Yes,
what
sir.
is difference between, already this is a established fact. So in
Yes, sir.
observation, anything different you find out or observe that need to be done?
Uh, so once the factor is a specific factor is deficient, it needs to be replaced. That is only the mode of treatment. If the particular factor is being deficient, it needs to be replaced. Like in factor 8, you can give cryoprecipitate, which is a rich concentrate of factor 8.
But it is
So
already
whatever
established.
the factor is
It is
deficient,
already
it
in
needs
clinical
to be given.
practice. Yeah, it's
Uh,
already in clinical practice.
yes, sir.
It is already being practiced. It's
Yes,
nothing
sir.
new in this. So anything new in your observation?
Um, so plasma containing all the coagulation factors, plasma containing all the coagulation factors, factor 8, factor 9, factor 12, factor 11, plasma, fresh frozen plasma containing all the coagulation factor which are involved in intrinsic coagulation pathway if the APTT is increased.
Okay, I think yes, it's just means your observation need to, but all these things what you mentioned is in practice in most of the hospitals, whether it is government setup or private hospitals. Uh, Okay, I think the new study you may plan or you may carry forward for the genome sequencing so that you find out certain, because now it's the era of the CRISPR-Cas9 where the molecular genetics may be applied to find out a better solution and cure. It's fine that as a physiologist you try to do something, whatever even being in practiced clinically, but yes, things to be revisit. Thank you very much.
Thank you.
I think already we have this 10 minutes is over, so question we may not allow. If anyone has question, they may mail directly to ma'am. She may be able to answer further queries. Thank you very much.
Thank you.
The next speaker with us is Dr. Neha Rani. Ma'am, are we audible to you? नहीं है.
Yes, ma'am.
कर दिया.
Good morning, ma'am. So,
Good
Dr.
morning.
Neha Rani will be having a talk on a study of adverse drug reaction among pregnant women and pediatric patients in tertiary care hospital. Ma'am, you can start with your talk.
Okay. Is my slide visible, ma'am?
Yes, ma'am.
Okay. Good morning, everyone. The title of my study is A Study of Adverse Drug Reaction Among Pregnant Women and Pediatric Patient in a Tertiary Care Hospital. Adverse drug reaction among pregnant women and pediatric patients are a significant public health concern. Due to the ethical and safety concern, the pregnant women and pediatric patient are mostly excluded from the clinical trial. So the safety data obtained on adults in clinical trial cannot be directly applied to these population due to the variable pharmacokinetic and dynamic changes. Therefore, the ADR monitoring and documentation are considered an essential practices for encouraging and ensuring the safe use of drug. Few studies have estimated that the incidence of ADRs in children was 9.52% and 10% during the pregnancy. However, more data is required to reduce the chance of ADRs among these population and assist healthcare professionals in making clinical decisions. Therefore, the present study was designed to evaluate the adverse drug reaction among the pregnant women and pediatric patient in a tertiary care hospital. The study was conducted at Kalpana Chawla Government Medical College and Hospital for 2 years. And during the study periods, the ADR reported by healthcare professionals of gynecology and pediatric department to the ADR monitoring center of our institute included in the study. The PVPI Pharmacovigilance Program of India suspected ADR reporting form was used to record the patient information and the suspected adverse reactions, in that the descriptions of ADR, date of onset, action taken, and also the details of suspected medication and concomitant drugs that are causing the ADRs, and also the relevant medication history and lab investigation report of the patient. So in this form, this information is recorded. And causality assessment was done with the WHO causality assessment scale criteria. The data were expressed as frequency and percentage and analyzed using descriptive analysis. Coming to the results, total of 54 ADRs were reported during the study periods, and in that, out of 54 ADRs, 40 ADRs were reported among the pregnant women and 14 ADRs were reported among the pediatric patient. And the most common adverse drug reaction that were reported in the pregnant women and pediatric patients are contact dermatitis, erythematous rash, and urticarias. And the other adverse drug reaction that were reported in the pregnant women are anaphylactic reactions, diarrhea, pruritus, vomiting, and shivering. And in the pediatric patient, this one severe case of Stevens-Johnson syndrome was reported due to vancomycin during the study period. Out of 87% of the ADRs were affected the dermatological system, and the remaining 9% and 4% affected the immune system and gastrointestinal system. And coming to the suspected medications that are involved in the ADRs among pregnant women and pediatric patients are antibiotics. Majority of the ADRs, like 60% of the ADRs were reported in the pregnant women, and 79% of the ADRs were caused by the antibiotics in the pediatric patients. And the other 20% of the adverse drug reactions were reported by the prostaglandin analog misoprostol, and the other suspected medications are diclofenac, iron sucrose, and ringer lactate solution in the pregnant woman, and in the pediatric patient, vitamin B complex and the paracetamol. In the antibiotics, mostly the majority of the ADRs were caused by the ceftriaxone. Mostly the ceftriaxone is in the group of cephalosporin, and the other ADRs that is caused by other antibiotics are amoxicillin, ampicillin, azithromycin, cefotaxime, ciprofloxacin, metronidazole, nitrofurantoin, and vancomycin. And in the pediatric patient also 35% of the reactions were caused by ceftriaxone. According to the WHO causality assessment criteria, the 65% of the adverse reaction were found to be probable, and 35% of the ADRs were categorized as possible. Coming to the summary and conclusion, during the study period, a total of 54 ADRs were reported by the healthcare professional of gynecology and pediatric department to the ADR monitoring center of our institute, and the 40 ADRs occurred among pregnant women, and 14 ADRs were reported in the pediatric patient. Majority of the ADRs were observed in the age group of 21 to 30 years, and 3 to 5 years in pediatric patients. And antibiotics were most commonly implicated in causing the ADR among pregnant women and pediatric patients. And the most commonly reported adverse drug reactions are urticaria, contact dermatitis, and erythematous rash. The reasons may be the overprescribing and irrational use of antibiotics make this vulnerable population more susceptible to the ADRs and antibiotic resistance. So therefore, there is a need to create awareness among healthcare professionals regarding the spontaneous reporting of ADR for ensuring drug safety and reducing the morbidity and mortality among pregnant women and pediatric patients. Thank you, sir. Thank you.
Thank you, Neha, for a very, very relevant study and observation.
Thank you, sir.
Now, the question you find out that majority of the ADR,
Yes,
whether
sir.
contact dermatitis, urticaria,
It matters,
what,
rash, sir.
yeah.
Yes,
So,
sir.
what was the impact of your study? Did you report it to head of the institute or the pharmacovigilance committee? Obviously, you reported this ADR. Whether it was recorded.
Yes, sir. All the ADRs that are included in my study, they were reported to the Pharmacovigilance Program of India through the Vigiflow software.
No, but if it is reported, recorded, authenticated, so what was the impact? Because you find out that antibiotic is the most common cause of ADR among the study group you included, like pediatrics and pregnant women.
Yes, sir.
So, is there any change in this use of antibiotic or after this follow up your study, at
Yes,
least in the institutional
uh,
guidelines of antibiotic use?
yes, sir. Previous studies also, and in my study also, the antibiotics were the main cause of causing the ADRs among all the population. So therefore, the WHO also started a antibiotic stewardship program to basically to promote the appropriate use of the antimicrobials, and also
No,
to
no, no, no.
improve the.
That is fine. That is fine.
Yes,
I
sir.
agree.
Yes.
want to, as per your institution, because it is the ADR of your Kalpana Chawla Medical College, Karnal.
Yes, sir.
So have you submitted this report to, because it is very, very relevant to the patient and the beneficiaries and even the staff, the doctors, everyone. So you
Yes,
must
sir.
be knowing that Dr. Jagdish Dureja, he is the director and he is
Yes.
professor anesthesia.
Hanji, Hanji.
So have
Yes,
you
sir.
submitted your report to implement for your institute? Because if you are doing research and
Yes.
if there is no implication based on that, so there is no meaning of that. So
Yes.
whether any policy or guidelines or SOP being drafted based on your study, or they want further to include the sample size to make it a policy or SOP. So what was the impact of your study?
Yes, sir. In our institute also we follow this antibiotic stewardship program. These my study also collected the ADRs. Sir, we only collected the ADRs because in our pharmacology department is involved in the ADR monitoring center of this
Okay,
institute.
okay.
So
Now
we already,
ADR include AE and SAE. How many of your SAE amongst all the ADR?
sir, this serious, sir, please
A
repeat
serious
the
adverse
question.
effect means
Yes.
any patient required hospitalization after this ADR reporting
So,
out of the 100.
sir, in my study, no, all the ADRs were recovered and no deaths were reported in my study. Only one case of Steven Johnson syndrome, and that patient was hospitalized due to this vancomycin. That
Okay.
patient,
So
but
that is
that patient
one
also
SAE.
recovered, sir.
Yes,
Yes,
yes. But any patient require hospitalization, that is
yes, sir.
SAE.
That
So,
information we.
so whether it was reported to the National Pharmacovigilance
Yes,
Committee?
sir. Yes, sir.
Okay,
These all
okay,
these ADRs. Okay.
okay, fine. Thank you.
Okay, sir. Thank
Thank
you,
you.
sir.
Thank you so much, ma'am. Now we have one more speaker with us, Dr. Suyog Sandhu, and he will be having his talk on an interprofessional and interventional approach to improve the mental well-being of medical students for better academic performance. Are we audible?
Ma'am, may I start presenting? I shared my screen. Is it visible? Dr.
Sir,
Suyog
इन्होंने
here.
Yes, ma'am, we can see your slides.
Okay. So may I have the permission to start?
मैम स्लाइड को फुल स्क्रीन कर दीजिए.
Yeah. Done. I think it's coming to your place. Is it?
Yes, ma'am. Thank you so much.
Thank you. So a very warm namaskar to one and all present. Myself, Dr. Suyog Sindhu, Assistant Professor, Department of Pharmacology. This work is part of my FAMO fellowship that I carried out at Mahai Manipal. So on behalf of my team, I present to you an interprofessional interventional approach to improve the mental well-being of medical students for better academic performances. The literature witnesses that high level of stress can obstruct the learning of medical students by impairing their concentration, problem solving, and decision-making skills. Through this project, we determine the impact of the interactive sessions on relieving perceived stress and anxiety of the student, along with impact of such sessions on motivation for learning. Our objectives were, firstly, to form an interprofessional education, that is IPE team, then to design a module for improving mental well-being of undergraduate students, and finally to take interactive sessions as per the module. The study was done on 72 second-year MBBS students after informed consent. Intervention was done by way of 8 interactive sessions spread over 8 weeks. Pre and post tests were done using validated scales of Hamilton Anxiety Rating Scale, that is HAM-A, Perceived Stress Scale, that is PSS scale, Motivated Strategies for Learning Questionnaire, that is MSLQ scale. Our IPE team comprised of a clinical psychologist who gave us the tools for assessment and also helped in validation of the module, a medical teacher for recruitment of the students and for taking interactive sessions, a psychiatrist for treatment of stress and anxiety if required, and medical students who shared the factors for stress and anxiety from their perspective. The highlights of the results that we obtained are as follows. The number of male participants in the study was 46. There were 26 female participants. No significant association of stress with gender was found in the study. Then it was found that there was reduction in number of students with high perceived stress after our intervention. And this reduction was to as much as 72.41%. There was increase in number of students with highest motivation for learning. This number actually doubled, and it was like 100% increase in number of students with highest motivation. The difference in means of HEM-A score was highly significant. That means that after the intervention, the number of students with anxiety was reduced. We also took the feedback from the students for the intervention, and they shared that they were very much satisfied with the mode and content of the module. What we liked the best was that they felt thought of and cared for. The table shows the significant difference between the pre and post test means of PSS and HEM-A scales. This table clearly indicates, like this chart actually, you can see here this is the number of participants. This is the category of stress, showing this figure shows the changes in PSS. So you can very well see here that the number of participants, this blue color is indicating pre-test mean, and this is post-test. You can see the number of students having high perceived stress decreased after the intervention. Regarding MSLQ, here you can notice that the number of students with motivation in the more than 75th percentile, this number increased from 18 to 36. That is just doubled, 100% increase in the number of students with highest motivation. That is in the 75th percentile. Regarding HEM-A, after the intervention, you can see the number of students with mild anxiety that increased. So we concluded after the intervention that interprofessional intervention approach of interactive sessions can actually improve the mental well-being of medical students for better academic performances. And based on this project, in future, we plan to inculcate the interprofessional well-being module in medical curriculum for second phase students, and also to establish interprofessional student well-being clinic at our university. In fact, I'm already in talks with the DU Student Welfare at my institute at KGMU, and things should work out in near future. And from bottom of my heart, I acknowledge the Mahir Prema Institute for supporting me, guiding me, Professor Dr. Siddharth sir, my mentor Shushrut sir, my institute KGMU, my co-fellows at the FEMA, and also the students who participated in the study, and also the team, the Epicon team, who gave me the opportunity today to present my work. Thank you so much. These figurines, actually, they have been innovated by me to represent medical students. I call them Shushrut and Sneha, and they have been copyrighted. Thank you from my side. I'm open for the questions, if any.
Thank you, Dr. Shushrut. Study context of the students. So I want to know that whether this study was conducted, I mean, when the physical classes were started or during the virtual session?
So this was actually done in the COVID period.
During COVID. So
yes.
Obviously students must be attending online.
So yes, the sessions were taken online, but it was a time when the students were called back to college. But because there was paucity of time, I was taking the sessions online. The students had started coming offline.
So did you follow up after that also? Yeah, this is just one time study. Second thing, because wherever the students are involved in any study, you have to sign an undertaking that you won't be involved in any type of formative assessment for the students.
Pardon sir, I couldn't get you. Not to involve the students in?
No, whenever you are doing any such type of observational study, so I don't know whether you are examiner or not, and you are a assistant professor pharmacology. So obviously second year student, so a direct contact is there. So
Okay.
there is a conflict of interest. So did you submitted undertaking to head of department that you won't be involved in any type of assessment for the students? Otherwise, this observation may be biased, may not be correct. Was it there?
Okay, sir. May I take a chance to respond?
There is a conflict of
There is
interest
some
in
disturbance. Yes, sir.
a faculty involved in study for the same year student. If it is a first year or final year where you are not directly involved, but because they were second year students and you are a faculty of second year, so you must submit one undertaking to head of department and head of the institute that for this academic session you won't be involved in any type of assessment of those group of students enrolled in your study.
Yes, sir.
Was that followed?
Yes, sir. Sir, actually, this undertaking was not required because we already have selected examiners for our this second part student, and I was not one of them. That was from the very start of the study. I was not one of the examiners. I was not supposed to be involved in any type of marks given to the student. So that type of undertaking was not required, and I was aware of this concern that you have just not raised. So I kept that in mind, sir.
Thank you.
Thank you so much.
Dr. Sandhu, one question. Okay.
So,
One question.
so
Please be connected.
What was the role of nutritionist in this study?
yeah, I'll just share you my module in a second. Can you see my screen? Is it visible?
Yes, ma'am.
Okay, so this
Not
you
you.
can see.
No, no,
Yeah,
not your screen, ma'am.
yeah,
Share
you
your
can't
screen.
see. Just 1 second. I think it got
Just
out there.
answer that.
I'll share once more. Yeah, actually, my module had one of the sessions on nutrition. So that's what I wanted to show you.
Ma'am, it's
Uh,
okay. You
No,
can
your
just
time is up
answer
now. You
because
can
you
just
yeah,
have
it's
a
here. I
limited
think it's
time.
visible. Yeah, yeah. So this is the
just answer
module. If you
in one
can
or
just
two
see,
sentences.
I think it's visible on your screen. So you can see number 4. The session number 4 is on nutrition. You can see.
Okay, thank you.
So for this, I required a nutritionist.
Thank you
I hope
so
I
much,
answered your
ma'am.
question. Oh, thank you.
Thank you so much, ma'am. And no, sir. That was
Thank you all the speakers. Announce the
Thank you to all the speakers who have joined in. And this was our last speaker, and with her, we came to the end of this event. Thank you all for lending a patient ear. Now, can I have the opportunity to please call upon Dr. KP Kocher to kindly felicitate our judge, Dr. AK Pandey. Ma'am is currently working at AIMS New Delhi, and with extensive research work, she is also a keen learner of literature. Dr. A.K. Pandey is currently Dean Academics at ESIC Faridabad. Thank you so much, ma'am. And with this, this event is now, we are done with this event and we will continue with the next event, uh, Symposium 6. हाँ मैम का है और डॉक्टर रेणुका शर्मा वो है चेयर कर रही है डॉक्टर अशोक कुमार जारियाल
virtually connected है physical actually तीन पैरल तो एक वाला वो यूजी वाला that is वो ठीक है इसमें चेयर मैडम है और
डॉक्टर रेणुका शर्मा मैम
आ गई वो एक इधर घुमा दो चेयर
एक सिंपोजियम हो रहा है ना नहीं नहीं एक सेकेंड और कौन कौन ऑनलाइन है?
जयप्रकाश
निशांत वो लोग शायद हैं
त्रिपदीप सिंह भी हैं शायद।
दीप से तो आई थी ना तो
स्टार्ट कर दो फर्स्ट सेशन हम ढूंढ रहे हैं
अच्छा यहाँ जब मुझे कनेक्ट करना होगा पीपीटी, जब वो लोग स्पीकर्स के बारे में बोलेंगे तो कैसे कनेक्ट होगी?
ये कनेक्ट नहीं होगी उस पे
नहीं होगी।
ये इस पे दिया नहीं हुआ इन्होंने। ये वाला दिया हुआ है हाँ तो फिर आप बस स्टार्ट करना है यहाँ पे एक बार करना एक बार स्टार्ट करो एक बार
हाँ जब मैं आपको बोलूँगी
वो करो एक बार देख लेते ना ट्राई करके फिर बाद में क्या है
आज क्या है? 4 10 मिनट्स। इनको बोलने को तो बोला है, कल भी बोल रहे थे। हाँ कल भी था यार।
इसमें जरियाल सर है ये शेयर करो
ठीक है जब मैं आपसे बोलूँगी तब करिएगा, अभी नहीं जब मैं आपको बोलूँगी तब करिएगा। मेरी स्क्रीन शेयर कर दीजिए कर दीजिए। शुरू करते हैं ना इसी पे जाना है वही तो लगाया है, वही लगाया है। स्क्रीन पे आ नहीं रहा है भैया। हाँ ये डाल दीजिए। Good morning to one and all. If I can have attention. So we are all here again to start with the next event or the second event lined up for the session. That is symposium number 6 on clinical neurophysiology, opportunities for physiologists. The speakers for the talk are Dr. Ashok Kumar Jaryal, Dr. Hansraj, Dr. Mrunal Pathak, Dr. Nishant Sampath and Dr. Tripad Singh. To chair the session, may I please introduce you all to Dr. K.P. Kochar and Dr. Renuka Sharma. Ma'am, I request you to please take the seats. Dr. K.P. Kochar is currently working at AIIMS, New Delhi as professor in the Department of Physiology. Not limiting to medicine, ma'am has earned degrees in literature. She has done MA English, diploma in French, and Pragya in Hindi. Her area of interest being nutrition, Indian diet, integrative physiology and cognitive physiology, ethics and medical education, and medical humanities. Ma'am has done an extensive research work. Her latest study being a brief review on altered gut microbiota and metabolites in Parkinson's disease. Ma'am has 53 published articles to her name. We welcome you, ma'am. None the least, Dr. Renuka Sharma is Director, Professor in Department of Physiology at Vardhaman Mahavir Medical College and Safdarjung Hospital. With 24 years of undergraduate teaching, including 6 years of residency and 16 years as faculty, ma'am has been guide for MD, PhD and MBBS students. Ma'am has been responsible for various administrative duties, being faculty in charge for undergraduate academics, in charge for internship program and many more. Ma'am is also a subject expert at UPSC, National Board of Examinations, AIMS and ICMR Faculty Assessment Board. Ma'am has published several research papers in national and international journals, apart from contributing 2 chapters in textbook of gynecology. We welcome you, ma'am. I now request our esteemed chairperson to kindly introduce our distinguished speakers and conduct the session.
Good morning all and welcome to this very important symposium on clinical neurophysiology. I remember about 2 years back, Dr. Pandey. Good morning all and welcome to this very important symposium on clinical neurophysiology, opportunities for physiologists. And it is my proud privilege to introduce my colleague, Dr. Ashok Kumar Jaryal, who has been the guiding beacon in this field for the past maybe 10 years, and he established and originated the field of intraoperative neuromonitoring, which is a very important area where physiologists can handhold with the clinicians and the researchers, including the trauma, ortho, and neurosurgery department. Through his various research publications in the field of neurophysiology and vascular function, testing in health and its alteration in diseases, Dr. Ashok has been a pioneer clinical scientist, a pioneer researcher, academician, and more importantly, evoking and motivating many medical students who were kind of afraid of so-called cockroaches and frogs to join physiology and join hands and teach the clinicians on what is the latest in the field. Thank you, and we welcome you all.
Dr. Hansraj is not able to join us, unfortunately, but we are now happy to move on to Dr. Nishant Sampath. I'm sure he's a very familiar face to you all here, and he's a consultant and lead neurophysiologist at the SRM Institute in Chennai. And of course, he's again been one of the pioneering neurophysiologists who went into intraoperative neuromonitoring, has been responsible for recording and analyzing almost 2,500 surgeries. He is the recipient of the Eloshke Research Prize and for the best paper submitted in respiratory physiology, and is a known face as a guest speaker in several national and international platforms. Thank you, Dr. Nishant, for being here. We're very happy to welcome you. And we're also now, we come to the fourth speaker, Dr. Tripadeep Singh here is again a very familiar face, and he's been working hard over the years, to popularize neurophysiology as an option for physiologists. So he's the international sleep specialist and also the director of Academy of Sleep and Wake Science. He's preparing doctors and technologists for various certifications in the field of sleep medicine and sleep technology. Apart from that, he's also the program director for India's first STAR program, approved by the American Board of Polysomnography Technologists, and has published 3 books on sleep technology. Currently, he's also working on developing India's first online sleep consultation platform, a very important initiative, I would say, in collaboration with REM 42. So thank you very much, Dr. Tripit, for joining us, and we welcome to the symposium.
Now it is my pleasant duty to start the symposium. Dr. Pandey, if I may. हाँ, Dr. Ashok Jaryal, I would invite him while Dr. Tripat joins us shortly. I think we can invite the symposium leader and the pioneer in clinical neurophysiology, Professor Ashok Jaryal, to kindly impress and motivate our learned young physiologists who want to make a career in clinical neurophysiology.
Thank you, chairpersons, for kind introduction to me and our co-speakers. As physiologists, medical professionals, we have three responsibilities in institutions: teaching, research, and if whenever possible, patient care. As teachers, every medical student remembers their physiology teachers. We've done excellently well as a teachers. I mean, exceedingly well. I mean, you ask any student throughout the country as a faculty they'll always remember the physiology teachers. That's the power of physiology, I guess. The subject is such that it just attracts you because it links things. The second domain is research, where again, we have made reasonably good efforts in different institutions, and we are still engaged with it. One area, somehow, we perhaps missed the bus, or opportunity didn't exist many years back, that we could not capitalize on our ability to interact with clinicians and occupy that space. So what I would say that what we have done is not create something new, but perhaps the space which was already existing, we're just filling that up. And to our surprise, the hesitancy that we felt the clinicians would give us, it was actually reverse. They were very welcome. They felt that they have become tools in service, and because of the workload that they have, they really do not have time to engage and get the translational things done. And for them, people with teaching and research background who have time and expertise at their hand are going to maximize their needs. And in medical college institutions, ultimately the whole system is built for patients. If patient didn't exist, no medical college wouldn't exist, hospital wouldn't exist. Because we need doctors, department like physiology exists. Ultimately, it draws from the patient, and the loop has to be completed, wherein we not only train them to become doctors, and when time comes, also assist them in doing their practice in the best manner. Technological changes in last few decades have brought in these opportunities. Here, parallelly, how things may go. If you see radiology as a field, is a top branch today. And if you see, wouldn't that should have been the specialty of anatomy? It should have been a super specialty. It's nothing but imaging. But somehow, anatomy missed the bus, in my understanding. If they were into, the first x-rays we saw were in anatomy department. The imaging is anatomy's domain, anatomy. But somehow, whatever it may have happened, I feel they missed the bus. If they had been engaging in clinical at the 60s, 70s, when the USG came, it would have been done by anatomy. When the CTs came, it would have been done by anatomy. And anatomy would have been the top branch. I fear the same for our field also. I fear the same. Technology will come, somebody will occupy the space. Nothing is going to remain vacant. And technology already exists. Sleeps has been there. Professor Malik, Dr. Tripath, and others started this field at AIIMS in collaboration with Americans, and it's picking up in our country. There's a huge demand. There's nobody. Dr. Nishant is a independent consultant. You ask him, what is the demand? He has lost today's work to be with us, because that's the way it is. Also, when you look at respiratory, GI, there's a huge demand. So there are people who want to do things. There's a demand. Where is the problem? The problem is linking up. And we feel that our department, physiology, its own not only just the existence, because in Americas, the subject as physiology is now declining, it's integrated. In most Southeast Asian countries, you do not have MD physiologists. It is the lectures are being taken by clinicians, and because they have to make it up. Things will go on, whether you exist or not. Things will go on. And we fear that when the pressures of finances and administration comes on medical colleges as well, the first to cut would be us, whether we like it or not. Because if physiology, somebody comes with the idea that let it be taught by, clinicians, where will we go? And as of now, 70% of MD seats remain vacant in the country year after year. Year after year. It is also now, initially AIMS, Delhi never had a problem, but you look at the newer AIMS coming up, the seats are still going vacant. Will this catch up to us in Delhi? Maybe, may not be. Hopefully, Delhi has its own attraction that we will keep getting our MD students. But what about the other medical colleges? The field has to be made attractive. And by attractive, we don't mean that we should give up our basic sciences. That must be there. Teaching must be there, but we can add on as a career option for physiologists. And with me, I have two people who actually took the leap. It's a jump to leave the academic safe environment, to put it that way, to go into a private setup. Professor Hansraj is not here today. He is one of the few people who were taught directly by Professor Paintal. And I thought he could come here and share his, which now we write articles about Professor Paintal.
And he was one of the original practicing
physiologists. So, Professor Paintal used to tell Professor Rao, who told us what he used to tell Professor Rao, not to, and one is the clinician, says, keep clinician under your thumb. That was Professor Paintal's mindset, that you tell them what to do. They are the hands, you should know what they have to do. You do research and tell them this is the best thing to do. Of course, that was Professor Paintal who could say that. He has the command to say that. We are still very, very lower, and we would request the clinicians to let us in rather than telling them as to what to be done. So both Professor Dr. Tripath and Dr. Nishant took that jump away from the safe havens of medical colleges, and if I felt they are the right people to lead. I am still in the safe haven. They are the ones who took the leap.
Now the boundaries are diminishing, so
yes,
we are in
right,
between.
absolutely. And we also have Professor Mrinal Pathak. She'll be joining us online. She's also in a safe haven like us, but she has taken as a lead, as Professor Pandey here has taken and others HODs have taken, to get the department directly into the clinics. They have taken space in the medical hospital. So we will run these facilities for you. And I think that mindset change and leadership is very much required for us to change the nature of physiology the way we are. So I would request the thank you chairpersons for giving me this concept as to why we are having this symposia. The symposia is to show our physiologists that there exists a huge life. There's a life beyond classroom. We tell our students, life beyond classroom, holistic life. So there's a life beyond teaching and research for physiologists, and that life needs to be embraced by all of us. Thank you, chairpersons, and now may I request them to continue with the presentation, ma'am.
We would also take this opportunity to introduce Dr. Mrinal Pathak. I think she'll be starting now. Right. So ma'am is joining us online. She is the head of physiology in the Department of Physiology in AIMS Nagpur, and she's been the former president of the Academy of Physiology for 3 years, 2017 to 19. And ma'am has contributed immensely through her varied research works in physiology. And now, like Dr. Jaryal introduced, she's taken us on into the clinical fields as well. So thank you very much, ma'am, for joining us. And we would now invite you to begin the symposium. A small request to all the speakers. I think we're running almost 1.5 hours behind schedule. So kindly, I understand we have a lot to share, but we will need to restrict the times to within 15 to 17 minutes. Thank you so much.
Dr. Mrunal Pathak, ma'am, can you hear us?
Yeah. Can you hear me?
Yes,
have
ma'am,
joined.
you are audible.
Yeah. Can I share my screen?
Yes, ma'am, please. Ma'am, we can see you. I can see your screen.
Yeah.
Yeah, ma'am.
Can you see the screen?
Yes, ma'am.
Yeah. Right. Thank you. Thank you for a wonderful introduction, which has been given by ma'ams, both the esteemed chairpersons of this session. And I thank Dr. Ashok Jarial for making me a part of this wonderful symposium. I also thank the organizers of APICON, Dr. Asim Pandey and Dr. Asim Das and Dr. Pandey, for inviting me to be a part of APICON. I was to come physically in February when it was scheduled, but due to prior commitments, I could not join physically today, but I'm happy to join online and be a part of this session. So without further ado, I would like to start with my talk, as the symposium is on clinical neurophysiology, opportunities for physiologists. I will be covering the domain of the electrodiagnostic studies, which includes the nerve conduction studies, EMG, evoked potentials, ERPs, and I will be covering the nerve conduction study. As the time is short, I don't know if I will be able to complete my presentation. Whenever you feel deemed that the presentation needs to be stopped or curtailed, please let me know, because there is a lot to tell and I don't want to take up other speakers' time. So an overview of my presentation will be, as Dr. Jarial has said, there is a lack of awareness and need for the physiologists to leap into this field of clinical neurophysiology. And we say that this is a perfect field for a physiologist or a neurophysiologist per se. What are the common applications and cases of neurophysiology? What are the basics of NCV in upper and lower limbs? Theory versus practice, and the future it holds for us physiologists. Now, EMG, NCV, evoked potentials being a part of clinical neurophysiology is hardly done by a physiologist. We see across the globe, across the world, or across India also, that many people are taking up this branch. As Sir has said, that the clinicians are already into it, the physician is into it. And even now, even the physiotherapists are taking up this branch. But we as physiologists, we are refraining from this branch, taking up this branch. The reason being, there are no specialization courses offered by the physiology societies or departments across India to train us in this. There are very few labs which are set up by our pass out graduates. I'm happy to see that my co-fellows, Nishant Sampath has already leaped into it, but there are very few examples like him who have already taken up, left their safe domains, as Sir has said, and gone on to practice neurophysiology in the clinical settings. Now, why clinical neurophysiology for the physiologists? This is because the physiologists have a knowledge about physiology of the nervous system, right from the molecular level to the systemic level. So the in-depth knowledge of a physiologist cannot be shared by the clinical counterparts. Clinical neurophysiology is also an extension of clinical examination. The tests are so customized that they are case specific, and they require the knowledge of the basic neurophysiology to modify as the case presents to us. This is because at times, many times we see patients and many unorthodox tests are required to be done. In a conventional mode, there are some subsets of muscles and nerves which are to be studied for a particular presentation of a case. But when in a clinical setting, we see that we have to, bifurcate this, and we have to go on to other subsets of muscles and nerves to study the whole patient per se and come to a diagnosis. So many unorthodox tests need to be done at a clinical settings, and this can be possible only if we have an in-depth knowledge of the neurophysiology. And I feel that a physiologist or a clinical neurophysiologist is the best suited to do these type of tests. Now, why the physiologists do not wonder here is because we remain more of theoretical. We do not go into the clinical zone because it has got a lot of shades of gray. We have to experiment, we have to correlate, we have to integrate, we have to diversify. So this is a region where the physiologists are lacking, I believe. I don't say all, but many of us. So we remain theoretical. It is time that we go out of this theoretical domain and venture out into the gray. Coming to the basics of electrodiagnostic study. Now, as I have already said, it includes the nerve conduction studies, the repetitive nerve stimulation, the late responses, the blink reflexes, and the needle electromyography. Now, this is again an extension of clinical examination. So you have to know a proper clinical examination. You have to have the results, the symptoms and the signs of clinical examination. And in each case, the study is individualized. It is based on the neurologic examination and the differential diagnosis. And it has to be modified in the real time as the study progresses, patient to patient. So as this information is gained, when you conduct the studies have to be modified. Even if the clinician has said that you do not do this test, so you do only this test, we have to take the call as we are evaluating the patient. Now, coming to the basics, the principal goal of every electrodiagnostic study is to localize the disorder. And the localization of the disorder is whether it is neuropathic, myopathic, at the junction, the neuromuscular junction, or higher up in the central nervous system. So you can localize neuropathic abnormalities like neuronopathies, radiculopathies, plexopathy, mononeuropathy, and polyneuropathy. Myopathies, whether it is a proximal disorder, distal, generalized, or craniobulbar disorder, and in the neuromuscular junction, whether it is presynaptic or postsynaptic. Coming to neuropathic localization, you are able to diagnose by doing the NCV which fiber types are involved, whether it is sensory, it is motor, or mixed. What is the pathology, whether it is axonal or demyelinating, and whether the course is acute, subacute, hyperacute, or chronic. In myopathic localization, you are able to diagnose the distribution of the disorder, whether it is proximal, distal, craniobulbar, generalized, symmetric or asymmetric, and also the severity, and whether it is a degenerative or a myopathic disorder, and the temporal course of the disorder. So also in the neuromuscular junction, you are able to diagnose the distribution, the pathology, and the etiology of the disorder. The cardinal rules of nerve conduction studies and EMG studies is that it is an extension of clinical examination. I'm repeatedly saying this. We are into the clinical domain, so we have to know this, that the clinical examination comes first. Now we have got a patient with a complete clinical examination done. Question whether the findings of the electrodiagnostic study are relevant to the clinical problem. When you are in doubt, think of two things. Whether there are any technical factors involved in conduction of the study which you have done, or whether you have to re-examine the patient and the clinical examination needs to be evaluated. Always think that there has to be a clinical electrophysiologic correlation. So revisiting your study or revisiting the clinical examination is always safe. Before coming to the diagnosis, do not overcall a diagnosis. Another domain which we can venture out into is the neuromuscular ultrasound, which is also complementary to nerve conduction studies. It cannot replace the nerve conduction studies. So this is another rider that you cannot replace ultrasound with the nerve conduction studies. Now, ultrasonography is the practice of using sound waves to create an image. High frequency linear array transducer is used for neuromuscular structures, and low frequency transducers are used for deeper structures. So we have a neuromuscular probe for the machine with a transducer of 18 to 6 megahertz transducer, which is commonly used. Now you can see here in the cross-sectional view of the median nerve I've taken, imaging has done at the distal wrist crease lying above the flexor digitoris tendons in the carpal tunnel, that is in the A. So you can see the median nerve here, MN. You can see the median nerve in the carpal tunnel, that is A. And you can see the median nerve in B, that is in the mid forearm. Now, the cross-sectional area of these three areas of median nerve is taken into consideration to diagnose the carpal tunnel syndrome. So you're going to get the cross-sectional area in the region A is decreased. That will be diagnostic of the carpal tunnel syndrome. Physicians who perform electrodiagnostic studies are best suited to learn and perform neuromuscular ultrasound. So this is another domain we can add to our clinical neurophysiology clinics. It is essential to emphasize that it is complementary to nerve conduction studies and not a replacement to the nerve conduction studies. The nerve conduction studies may be able to identify a neuropathy like an ulnar neuropathy at the elbow, but they cannot discern what is causing it. Whereas a neuromuscular ultrasound can actually tell what is causing it. Example, whether there are any bony spurs, whether there is any callus, or whether there is compression, or there is a cyst. What is the pressing pathology that can be discerned or that can be learned from the neuromuscular ultrasound? So it is complementary to the electrodiagnostic studies. Now coming to the motor conduction studies. These are the sites where the motor conduction studies are done in the upper limb and the lower limb, the median nerve and ulnar in the upper limb, the peroneal nerves and the tibial nerves in the lower limbs. This is how the placement of the electrodes is. This I've taken in for the median nerve. Both the sensory and the motor electrode placement is seen, where you can see that the motor recording electrodes are placed on the muscle, the distal muscle, supplied by the median nerve, the abductor pollicis brevis, where the recording electrode or the active electrode is placed on the belly, and the reference electrode is placed on the tendon of the muscle, and the stimulating electrode is placed at two sites, at the wrist region and at the elbow region. So there's a proximal site and a distal site where the stimulating electrodes are placed, and you can see that the cathode of the stimulating electrode is facing the cathode or the active recording electrode. This is how the placement of the electrodes are for motor conduction velocity. For the sensory, there are ring electrodes which are used because the distal muscles are in the digits. So there are sensory recording electrodes which are the ring electrodes. Again, you can see that the cathode is placed towards the cathode of the stimulating electrode. Now, I think I'll skip this. How do you optimize the stimulator position? Because of lack of time, we will go to the motor conduction velocity calculation directly. You can see that there are two sites where you're going to stimulate. This is the muscle. This is the nerve which is supplying the particular muscle. Or you can take median, ulnar, any which one. This is the distal site where you're going to stimulate. Distal means closer to the muscle, and proximal is away from the muscle near the origin of the nerve. And you record the motor conduction velocity or the CMAP, which is recorded, and the latency is calculated. This is how the screen looks like when you calculate. You have got an x-axis which gives you the duration. Here it is written 3 meters per second per division. And the y-axis is the amplitude. Here it is standardized at 2 millivolts per division. So it is standardized, and you record by stimulating at the wrist and at the elbow at the two sides. Directly you get the recordings of the onset latency, the amplitude, as well as the duration. So these kind of softwares and machines are available where you get the direct recordings. Now, how do you calculate the latency across? You have got two stimulating points. These are marked, and the distance between the two stimulating points is recorded in millimeters. The distance here is 284 millimeters between S1 and S2. Now you record the CMAP at S1 and record the CMAP at S2. You've got both the recordings. See the latency of CMAP at the wrist. Latency is 3.5 milliseconds. Latency at the elbow is 8.5 milliseconds. So there is a difference of latency of 5 milliseconds. The distance is divided by the difference of latency, and you get the conduction velocity across this nerve. Normal conduction velocity in the upper arm, in the arm is 50 to 70 meters per second, and in the leg 40 to 60 meters per second. Coming to the amplitude, you can see that you take the amplitude from the base to the peak. This is usually taken many times. Many books give peak to peak amplitude also. So you have to see what you have standardized or what your machine has standardized, whether it is the base to peak or the peak to peak, and accordingly you get the values. Coming to the latency, you have got two latencies, the onset latency and the peak latency. Now the onset latency is a little difficult to demarcate because it's quite confluent. And the peak latency, because it is at the peak, which is a sharp one, it is easier to mark, and therefore peak latency is taken. Now coming to the sensory conduction studies. Again, the sensory nerves, they are the ring electrodes which are placed G1 and G2 on the fingers in line over the nerve where the recording is to be done. The electrode distance is usually kept between 2.5 to 4 centimeters. Active electrode is placed closer to the cathode, the stimulating electrode. Ring electrodes are used in the fingers. Now you see the sensory nerve action potential. Now this is recorded in microvolts. The motor action potential is recorded in millivolts. So it is of larger magnitude, whereas the sensory action potential, which is recorded, is of a lower magnitude. So you have got a stimulus point or a stimulus artifact. Then this is a point where the recording starts and it reaches a peak and it drops down back to the basement. So this is how the sensory nerve action potential or SNAP is recorded. Now these are the sites for the median ulnar nerve in the upper limb and the sural and the saphenous nerve in the lower limb. So these are the sites which are taken for the recording of the sensory nerve action potentials in upper as well as the lower limbs. Now marking, as I said, marking of the onset latency.
Dr. Brinal, can you hear me?
Yeah.
Ma'am, I'm sorry to interrupt you, but we are really short of time. And can I request you to please wrap up in the next 2 minutes? So that we can finish on time and we have a next lecture also.
Right. So I'll say, So I'll just complete. I will not go into the carpal tunnel syndrome, which I was supposed to cover. I'll just give a brief overview. That difference between CMAP and SNAP is that technically CMAP is less demanding. Order of performing, you always perform the CMAP first and the sensory nerve studies later. Amplitude of muscle action potential is in millivolts, whereas in sensory, it is in microvolts. The gain you can see in millivolts is 2 to 5 millivolts, whereas the gain in sensory is 10 to 20 microvolts. Duration is longer for the motor action potential, shorter for the nerve action potential. Current required for the for recording the motor action potential is supramaximal or maximal, and for the nerve action potential, it has to be submaximal. So this is how the difference between the two is. You can see the difference, that the duration, the amplitude is quite different. And okay, so this is about the antidromic. So this is all. I think I should stop here. Patterns of nerve conduction abnormalities. I can say a little bit about abnormalities. You see the normal study, you have got a latency and a conduction velocity over here. B is showing axonal loss where both are reduced. In demyelination, you have got the distal latency, which is increased. So increase in latency and the conduction velocity is reduced. And you have got demyelination with a conduction block showing temporal dispersion at the end of it. So this is how you can differentiate the different kind of nerve conduction abnormalities with the nerve conduction study. So I think I'll stop here. I will not take into the F response or the late responses. Do I have time, chairpersons? Can I take into these?
Ma'am, another 1 minute, please. We are already overshot. So if you can summarize in 1 minute.
Okay, so these are the late responses. I will just take the late responses which are taken, that is the F waves and the H reflex. As the name suggests, it is late. It comes after the CMAP, after the motor. The reason why it occurs is that for the F wave, when the muscle is stimulated, the response, the stimulus is again antidromically brought back to the muscle, and this produces a wave which comes after the normal M wave. For the H reflex, the monosynaptic reflex is stimulated directly not by using the muscle receptors or the stretch receptors. The stimulus is given directly onto the afferent nerve, and the impulses go directly via the monosynaptic pathway to the anterior horn cell, and from the anterior horn cell, the effector to the muscle. So therefore, the H reflex is also obtained. So these are the late reflexes, which you can see here. These are the F waves, which are not very consistent, which keep on changing, whereas the H wave is relatively more consistent. Both these waves are recorded after the M wave. And this is the difference between the two. Now, I'll not go into the carpal tunnel syndrome. Maybe we can have some other session next time for the carpal tunnel syndrome. And I thank all the organizers and the chairpersons for giving me time for this. So I will not go into the details of carpal tunnel syndrome. Thank you so much.
Thank you so much, Dr. Malal, for sticking to the time. And it was a very illuminating talk. We learned a lot about the new complementary techniques as well. And thank you for summarizing everything. I would like to request all the participants online to please put in their queries in the chat box. And all those who are here, we'll take them up at the end of the symposium. Thank you so much.
Thank you, Dr. Mrinal. I just wanted to tell Professor Jaryal that seeing this first presentation, I think we should have a full 2 days workshop and symposium
Yes,
on clinical
yes.
urology, and
Totally
also
agree.
have some kind of certification fellowship or maybe going on to a DM, that is hopefully in the future.
Okay, thank you, ma'am. Now we invite our next speaker, Dr. Nishant, to please.
HD में होता है क्या this laptop is yes yes
Thank you.
You have a pen drive?
I have my external hard drive.
Go ahead. Tripat welcome. तब तक आप आए
No worries. We'll have a slight change in the speakers. Dr. Tripat will now be taking the session.
स्क्रीन शेयरिंग कैसे होगी Rajiv, handheld mic. So hi, good morning everyone. So what I will do quickly is I'll try to show you a pathway what physiologists can take as far as sleep medicine and sleep technology is concerned. And to show you the pathway, I will need to show you what is the US perspective currently as far as sleep medicine and sleep technology is concerned for you to understand what are the opportunities in Indian perspective. And I will give you a lastly 8-step approach if you want to advance your career in sleep medicine and sleep technology. You follow those 8 steps. I have done that. It's my personal journey. I'll share that with you in the last. There are different opportunities in sleep science. You can do basic sleep research, you can go in sleep medicine, you can have a career in sleep technology, you can have a career in chronobiology, or you can have a career in sleep epidemiology itself. Now, to understand the opportunities, let me show you the US perspective. In US, a typical sleep lab, they have got somebody called sleep physician who is the medical director. They have got somebody called sleep lab manager who manages the lab function on a daily basis. You have somebody called sleep technologist which handles the technical aspects in the lab. And then you have got other staff. Now, over the last years, there is a substantial increase in the prevalence of sleep disorders, particularly sleep disordered breathing, of which obstructive sleep apnea is the most common disease. In US, it has tremendously increased. Like in 1992, the study that was published, the prevalence of OSA was 2 to 4%. And this study coming out in 2013, it is showing 14 to 55% of the population have got obstructive sleep apnea. So disorders prevalence have increased, but see what has happened. The number of specialists who's taking sleep medicine in US, they have started falling after 2011. So prevalence of the disease is increasing, but the number of specialists is going down. And the reason for that is before 2011, after you do your residency in US, you can just take one exam and you will become sleep specialist. 2011, they changed that. They said you have to do 1 year fellowship and then only you will become a sleep specialist. And suddenly the drastic number reduced. Another change happened in US was that insurance companies said in 2008 that we will not pay for the level 1 studies which are done in the hospital, but we will pay for level 3 studies. Economically, gains came down. The number of study years increased. As a result, US saw a drastic fall in take-up of the sleep medicine in the country. But keep in mind, prevalence of disorders is not decreasing, it is increasing. So what they started doing is, they started, let's have alternate models. If we don't get enough sleep specialists, let's try to include internists, family practice physicians, pediatricians, psychologists, advanced practice registered nurses, physician assistants, to help the current pool of sleep physicians to handle the burden of sleep disorder. So they started empowering these other specialities to manage sleep disorders along with sleep physician. They started empowering primary care providers in their country, and this is happening in US and Australia both. So what is being very clearly shown, and I'm showing you just one study, there are a couple of them now, that primary care physicians, that is GPs, if trained in sleep medicine, they can manage sleep apnea patients as good as sleep medicine experts. And the question is, how many hours of training they underwent to manage sleep disorder patients? Most of the studies, 5 hours of training on managing sleep apnea patients by a sleep physician, and they were able to take care of the patients as good as any sleep physician trained in US. So what is coming up is, they are coming up with alternate care models where the sleep center is in the center where sleep physician is present, but primary care physicians around that center are being empowered to take care of patients, and if there are complications or difficult cases, they can always consult the sleep center. And I love this editorial which came a couple of years back. What future of sleep medicine is, you have to set up interdisciplinary academic sleep units as independent entities outside of traditional divisions and departments. This needs to be done. you need association should be dealt with other specialties such as dentists, psychologists, and sleep scientists. And lastly, education program which should include sleep medicine fellowships, training of research fellows, teaching of medical students and allied health professionals is required to take this field to the next level. Another thing they have started doing is they've started a new certification in clinical sleep educator so that along with sleep physicians, these people can handle the clinical aspects of patient management on a day-to-day basis to take off the burden from the sleep physicians. But they will always be under the supervision of sleep physician. So this certification they started in 2011 basically. Now they are trying to handle the burden in a very wise manner. They are kind of having different layers of manpower, sleep physicians, under them technologists handling technical aspects, clinical sleep educators handling clinical aspects in the sleep lab. Now, this is the US perspective. Number of disorders are going up, number of specialists are going down, alternate care models are being proposed, other specialties are being included to take care of the sleep disorder patients. In India, India is in a very unique position, I will say. We should learn from the mistakes what West have done and don't go the path, same path, and then realize we are committing the same mistakes. And I'll show you why India have a unique position. This is the prevalence of obstructive sleep apnea in India, and I'm showing you data for OSA in India because this is the best data we have. No other sleep disorder have been studied extensively in India. We don't have Indian data on any other sleep disorder. When I say sleep disorder, I'm referring to more than 84 sleep disorders, and OSA is just one of them. Our entire country's focus is on OSA. So what this slide shows you is there is high prevalence of obstructive sleep apnea, and I will stick to 3%, the lowest one, and I'll build up my case why India is in a unique position. If you look at comorbid conditions, this is Indian data, prevalence of OSA in Indian children is at 9.6%, diabetic patients, prevalence of OSA is 23%, prevalence of OSA in patients undergoing non-cardiac surgery is 38.5%, and prevalence of OSA in acute ischemic stroke patient is 60%. It's even higher than the general population. What is the situation in India as far as sleep medicine and sleep technology is concerned? We don't have full-time sleep specialists in India. It is being practiced by different specialties like pulmonologists, neurologists, psychiatrists, medicine, pediatrics, ENT, and physiologists have started taking it up now. But what every clinician is doing is part of their practice is sleep, like 10% or 20% of the time is devoted to sleep, but 80% to 90% of the time is for their primary specialty. Sleep technology is the worst in India. There is not even a single association to represent sleep technologists in India. And the technicians, they are the worst lot in India because they are made to work in pulmonary function labs during the daytime, then they are thrown in the sleep labs at night time, salaries are not good, and there are no regular positions for a sleep technologist in institutes of India. So we have PFT technician, but we don't have a sleep technician post at all. And I have seen suffer very good technicians because of this. They know very well the field, but because institute don't have a position, they have to leave the institute. So let me show you, Indian population is 1250 million. If I take prevalence of sleep apnea at 3%, we have 30 million people suffering from OSA at any point of time. How many labs are there in India? This is my number 300 to the best of my knowledge. No literature have this number. From my past 15 years of experience traveling all over India, this is my best guess that there are around 300 labs in India. One lab can take one patient per night. That means if these labs work day in, day out for 365 days a year, maximum 90,000 patients can be taken in 1 year. That means to have this burden handled, we need at least 333 years. They will not be alive by then. So the burden is huge. Clinical community is doing a fantastic job in managing these patients. But the problem is they are not enough. We all as physicians are not enough to handle this burden. But the good news is we are not alone. Who's with us? God? No. We need to use our imagination to contaminate science, come up with new models, and do something about it. We started a center in Pondicherry in 2009, and I started it. And I took it out of the At that time, I was not aware of the literature that I have shown you. I became aware of that later on. I took the center out of any department. I made it a standalone center where different specialities were sending the patients to us, and we were managing the diagnostic and therapeutic protocols in the lab. We were doing the patient follow-ups in the lab. And we had a tremendous experience with all the specialities, very happy with the outcome because quality control at the sleep lab level was excellent with all the trained physiologists handling it. I trained the entire manpower. I sat in the lab whole night for almost 1 year to get people ready to take over the responsibility. But keep in mind, if you are coming into this field, my slide is, you will need to get yourself trained in different aspects of quantification of sleep using the technologies, sleep staging, quality of sleep, sleep and driving, circadian rhythms, sleep disorders, neurophysiology of sleep and wakefulness. You will need to learn these techniques, except the last one. This is more research-oriented techniques in animal models, but rest all are clinical. You need to learn those techniques to understand different aspects of sleep and sleep disorders. And what you will be doing is, if you go down this path, you will be running diagnostic procedures in the lab, you will be running PAP clinics on the OPD side, you will be running a circadian lab to manage circadian rhythm disorders. So all this will fall under your responsibility if you go down this path. My vision for sleep physiologists is that you become the managers of the lab. You control the quality control of the lab. You train the manpower. You make sure you have enough infrastructure and manpower trained to take up the number of cases in your lab and do justice. I will call it working hand in hand with the clinical friends. They are doing an excellent job in the OPDs, but they don't have the manpower or time to come to the sleep labs and manage quality control, do the training, look at the sleep study data, do the follow-ups. It's very challenging for them to take out time from their primary practice. That is where your role comes in, that you take those responsibilities, work hand in hand with your clinical friends to achieve it. Summary is, India has a unique set of problems due to population size. You need to have a solution that fits Indian needs. US is not having sleep specialists, right? Doctors are not coming forward. And here we have a pool of doctors called physiologists who have forgotten their MBBS degree, and they are sitting there and not taking the initiative to come forward to express their clinical skills. I say, if these people can come forward, and if we can have one sleep lab in every country in India, in every medical college in India, I can tell you the infrastructure is going to be huge to make a big difference. My advice to you, step one, decide your area of interest in sleep science. When I say that, I mean, are you interested in basic sleep research, sleep medicine, sleep technology, chronobiology, or sleep epidemiology? This is the first question you need to answer. If you are interested in basic sleep research, good. India have a lot of opportunities. You have Dr. Baldev Singh Lab in AIIMS. It was headed by Dr. Malik earlier. They are doing fantastic work in role of pre-optic area in sleep and thermoregulation and male sexual behavior. Sleep Research Lab in JNU, Dr. Sushil Jha, excellent lab for understanding the role of sleep in memory and REM sleep mechanisms. NIMHANS Bangalore, Dr. Bindu Kutty is doing fantastic job in understanding the mechanisms of consciousness and sleep and the meditation. And then Sleep Disorders Research Lab, Shri Chitra Trindul, Trivandrum, Kerala, headed by Dr. Kamlesh Gulia and Dr. V. Mohan Kumar. They are doing fantastic work in sleep and pregnancy. Opportunities are there, you just need to decide what you want. Step number 2, if your interest is clinical, then my first step is, after listening to me, don't go to your management and say, I want a lab and I can do wonders with it. You can't do that. You need to get yourself educated, trained and certified in sleep medicine and sleep technology. And unless you do that, nobody is going to listen to you. You have to showcase your capabilities. To do that, my advice to you is take 1 to 1.5 years to get yourself trained. And the biggest question is, how do I get trained? There are plenty of opportunities in India. There are 4 societies in India pertaining to sleep. Indian Society for Sleep Research, the oldest one, then Indian Sleep Disorder Association, Indian Association of Surgeons for Sleep Apnea, and Southeast Asian Academy of Sleep Medicine. All these 4 associations, they have their annual conference. try to attend all the 4 conferences. You will learn different aspects at each of these conferences. ISSR, that is the Indian Society for Sleep Research, it conducts National Sleep Medicine course and National Sleep Technology course. And I can tell you, if you want to go in the field of sleep medicine and technology, this is your stepping stone. These courses were supposed to be held in February, but they have been postponed due to COVID. Dates will be announced soon. But I attended the first one in 2006 and kick-started my journey. Fantastic faculty from India and abroad come together, and they don't talk about research. They'll tell you the very basics that you need to kick-start your journey. They will not talk big things. They'll give you the very fundamental clinical knowledge that you need. Later on, you can build on that, but this is the stepping stone. Look for it. Go to ISSR website. And another thing Indian Society for Sleep Research have done is they have brought an international certification to India. So World Sleep Society, it conducts international sleep specialist examination, which ISSR conducts on their behalf once a year. Once you get trained, this is the certification you are going to target to demonstrate your capabilities to your clinical counterparts. Once you pass this examination, your names will go onto the World Sleep website, and anybody can confirm whether you have actually taken the exam or not. And I can tell you this is a big step. If your name comes on this website as a sleep specialist, the world is looking at you. The horizons are going to open tremendously. Indian Society for Sleep Research also conducts examinations for sleep technicians, and my personal request to you, if you want to go down the path of sleep medicine, the doorway name is sleep technology. You cannot go into the hall of sleep medicine without going through the sleep technology. This is your first stepping stone. Go for it. There are international certifications which you can take from India. Once you have undergone certain amount of training, you can target certifications in technology, which is highest certification in technology is RPSGT. This is recognized worldwide. Once you have it, anywhere in the world, you can become sleep lab manager. Not only India. I don't want you to go out. Stay in India. We need you. But I'm just trying to encourage you that things will be different. In clinical sleep education, the certification is called CCSH. You can target from India. Yeah, just 2 minutes. There are other international trainings out there, but they are very costly. This training from Australia is costing around $30,000–$40,000. This is the most latest one from Europe, but costing you around 15,000 euros. Now, I started Academy of Sleep Wake Science after coming back to India last year because there is a vacuum in training. There is no trainings, long-term trainings, I will say. So I started this Academy of Sleep Wake Science, under which we are offering different courses on polysomnography and titration, scoring rules, and if somebody wants to take exams, we have mock exams as well. Now, we have around 7 students from 7 countries are with us right now. Right now, all the courses are online, but it can fill your vacuum. We have written some books to help you out. And my last advice is, go for NSMC, NSTC, go for these certifications in this sequence. If you need help, ISSR is out there. My academy is out there. We can be happy to help you. And go to a sleep lab, spend 2 to 3 months there so that you learn the practical aspects. And to do that, go to ISSR website. I have made it. I have put a list of sleep labs there across India which can offer you some kind of training. So go there and explore it. Step 5, if you want to go to your management, calculate how many obstructive sleep apnea patients are there in your institute right now to show them that what they are missing. How do you do that? You can take this table, do your homework, and you will be all set. And when you are planning to go to your management, please keep in mind this advice. Don't go there and say, I can do sleep medicine or sleep technology. You have to go with a proper proposal, taking care of the scientific content, the financial content, the management consent, the manpower content. Without that, nobody is going to listen to you. And how to set up the labs, we have conducted webinars on how to do it. If you go to our website, we have put the webinars there free of cost. You can listen to them and kickstart your journey. This was on 25th February this year, adult sleep lab. Similarly for pediatric sleep lab. And lastly, please try to incorporate sleep medicine in undergraduate coaching. That is very critical. We tested on the basis of this that 2.5 hours are given for undergraduate or postgraduate teaching for sleep. We tested the knowledge of first year medical students in sleep. This we published in 2020. And what we found was the knowledge was very poor, and we did an educational intervention to improve the knowledge on certain topics. And what we found was we could, their knowledge prior was poor, but the post-test knowledge tremendously improved their scores. So simple educational intervention can work for your undergraduates. Do that. And these are some of the topics I advise you to include in your undergraduate curriculum. And lastly, get involved in public education on importance of sleep. This is very, very critical, totally neglected in India. Sleep epidemiology, nobody is paying attention to. We don't have even data on how many hours Indians sleep, what time they go to bed, what time they wake up. We don't have even this kind of data. There is tremendous opportunity out there. So with this, I stop. This is my roadway map of 8 steps for you. Thank you so much.
Thank you so much, Dr. Tripit. I think it's been a most fascinating talk, and I'm sure it's really rejuvenated people to look into this field. Thank you so much for outlining everything in detail. And if you could share your email, I think with the online participants, I'm sure they'll try to get in touch with you.
I can give this PowerPoint to the organizers.
Oh, that will be wonderful, sir.
You can share it with all the participants.
That's excellent, sir. Thank you so much. Thank you very much.
While Dr. Nishant is getting ready, it's also my pleasure to thank Dr. Tripadeep Singh and also Dr. Shok Jaryal for bringing the audience closer to him and to see how boundaries are kind of melting, and we are having education, research and clinical practice, the trinity of all mandates in any medical institute, reaching higher. Thank you, and he's pioneering this in the personal sector and domain. So we would love to collaborate with you in many ways.
You go directly.
See, once it comes there, you tell me. Once you see the screen, you tell me. Better to run it there. From there. Make it up. The time will not be. I'll take some other laptop.
आपकी पीपीटी आपने आगे 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 3.36 टेराबाइट सर, तो थोड़ा सा टाइम लेगा इसका टेराबाइट ना. This is the speed. And इसको ज़्यादा हिलाना नहीं चाहिए वायर, आई थिंक पूरा टाइम नहीं लेना चाहिए.
Can you copy it?
हाँ वही कर. अभी आपने कंट्रोल
कंट्रोल से किया.
हो गया हो गया हो गया. स्क्रीन शेयर क्यों नहीं करनी वाली? हाँ अभी कर. सर एक काम करते हैं, फुल स्क्रीन ले नहीं रहा तो हम विजुअल का
Takes time to load.
ओके.
Then Nishan, they start talking. We'll figure. Start talking. We'll figure. We'll take this. We'll start talking. Start.
करो स्क्रीन शेयर करो ये वाली.
Yeah. See, at the outset, I'd like to
full
thank
slide mode पे डाल रहे हैं तो नहीं चल रहा है, ऐसे
organizers
ही
of
कर लेते हैं.
PPI and Professor Ashok Serial for giving me this opportunity to talk about this field of intraoperative neuromonitoring. So the objectives of this presentation is to give an overview of practice of neuromonitoring. Okay.
No, we'll just do.
Okay. Yeah.
So we won't run show.
Okay. We'll see. So overview of practice of intraoperative neuromonitoring, and to present, if there is no technical glitch, I'll try to show some interesting intraoperative videos, and finally to discuss the feasibility of IONM as a sustainable career option for MD physiologists. So intraoperative neuromonitoring is essentially use of electrophysiological methods to assess the integrity of neural structures during surgery. It provides real-time feedback to the operating surgeon with regard to neural functions, and it's now standard of care for high-risk brain surgeries, spine surgeries and peripheral nerve surgeries, especially in the Western countries. The goal is to maximize benefits of surgery while minimizing loss of function. We can use it either to map, to identify neural structures. This can happen because of the anatomical distortion the surgical lesion can produce, or for serial monitoring. The whole theme is to identify injuries at the early stage of electrical failure and at the stages of reversible cell injury, so that we can do some corrective steps to avoid permanent neurological deficit to the patient. And we can also use neuromonitoring for research in basic science. For example, if new tract or new structure is found, we can stimulate and find out what exactly is its function. A whole range of surgeries could benefit out of intraoperative neuromonitoring. Neurosurgeries, spinal cord surgeries, orthopedic surgeries, ENT, peripheral nerve, and cardiothoracic vascular surgeries. A whole range of modalities are available with the neurophysiologist to pick up bits and pieces of information and solve the jigsaw puzzle of what's happening to the patient when the patient is under anesthesia. So we have to use a tailored approach. It's not like a clinical neurophysiologic technique where we follow all the
protocols, to the book. Here we have to improvise a lot. So, is our work limited to the operating theatre? No. As soon as the patient comes, the surgeon feels neuromonitoring is required, he will refer for neurophysiologist, and we do a basic workup. We assess their motor power, sensory power, and discuss with the surgeon as to what is the surgical risk. For example, in CP angle tumors, facial nerve is at risk. In spinal cord tumors, patient could end up with paraplegia. So we need to find out what exactly is the goal of neuromonitoring and accordingly decide on the modalities. And to facilitate these modalities, we'll have to discuss with the anesthetist to tailor anesthesia. And in the OT, once wheeling in procedure is done, anesthetist induces the patient, and then comes our role. We place electrodes and then we take baseline, and during the critical steps we serially monitor signals. And during neuromonitoring, we need to constantly optimize neurophysiological signals. The earlier speaker talked about optimization. We need to do a lot of that during surgery, and we need to set baseline, and we need to be in constant communication with the surgeons and the anesthetists, and give our inputs, and we need to interpret the data contextually with respect to the ongoing surgical step, changes in systemic factors and things like that. So, because there is a shortage of time, I'll just give a sneak peek of how all these modalities look like in the beginning itself, and then if time permits, I'll show a couple of videos. So, this is basically SSCP phase reversal. This is direct cortical stimulation and mapping of motor homunculus. This is mapping of subcortical tracts, corticospinal tracts by responses from one side of the body. And this is auditory evoked potentials that assess the integrity of 8th nerve and the brainstem. We can see waveforms from 1 to 5. These are corticobulbar MEPs from facial nerve. These are visual evoked potentials recorded intraoperatively during pituitary surgeries with suprasellar extension. These are standard transcranial motor evoked potentials. These are sensory evoked potentials. These are D waves, and this is what is called a bulbocavernous reflex. And this is how we place electrodes for lower cranial nerve monitoring. We place electrodes in the tongue, soft palate, and a special tube is used to pick up EMG of the vocal cords. And this is how spikes look during direct cortical stimulation. These are electrodes placed in the extraocular muscles for 3rd, 4th, and 6th nerve monitoring. So this is our role. Nobody else does for us. Physiologist has to do. And this is a common artifact that we find. This is a ringing artifact. This is recording of a lateral spread response. Can this light be switched off? Light. If there is if it goes into slideshow, there is an issue. This is a successful recording of transcranial motor evoked that can be off. Yeah, transcranial motor evoked potentials in a 2-month-old infant. It's quite challenging. Whenever we go to national and international conferences, the common question is, what is your youngest age where you could record MEPs? And we had a case of in a 2-month-old, and this is not just one time. We are able to do consistently. We right now have 5 to 6 cases where we could record. So moving on to some videos. So OT is not a very conducive environment, both with respect to people as well as with respect to the machines. So we need to be on constant vigil. Video is not coming. This is an older format.
Yeah, for PowerPoint.
Yeah. Okay. Where is PhD? So these are ringing artifacts that happen whenever we use a notch filter to take care of the ambient noise. One of the commonest scenarios where we help is requested is tumors close to the eloquent cortex. Eloquent cortex is that part of the cortex where whose lesion or whose injury produces a dense deficit. So it can be motor cortex, it can be language cortex, so on and so forth. So you can see that the tumor is very close to the primary motor cortex here, right? So the surgeon has to decide how to enter the tumor and how to remove the depth of the tumor without actually damaging the primary motor cortex. Yeah. So the first step to do this is identification of central sulcus. So we use a standard 8 contact strip a 4 to 8 contact strip to record a technique which is called SSEP phase reversal. So you can see that this is somatosensory evoked potential recorded directly from the brain. You can see that the waveform of the first 2 channels are going down, and at the same latency you can see that in the 3rd channel the waveform is going up. So that's called a phase reversal, and whenever you get a phase reversal, you know that that's where central sulcus is. So once you identify the central, although it's a common, it's a normal anatomical structure, it's not so easy to identify this during surgery. We get good illustrations on our anatomy textbooks, but it's not so when we open the skull. Okay, there is some process that's happening.
It goes into auto recovery, then it stops. So something is on the slide. So a huge file, it takes huge time.
Yeah, it's a huge file. It never happened. This is the first time. Okay.
So you can't keep talking otherwise.
Okay. So that's the first step, and sir? Yeah. So the next step is identification or mapping of the motor homunculus. So this is one diagram that we are often used to in our physiology textbooks. So Penfield was the first one who gave this concept of homunculus, but he himself comes up with a disclaimer that there is a lot of inter-individual variability. So although we draw it in this manner, on a given patient we don't know, or a given subject we don't know where the hand area is, leg area is, and so on and so forth. And it's even more distorted in the presence of lesion. So we record from muscles starting from face to leg, and then we stimulate a given area and look as to where the response is, and accordingly map the motor homunculus. Once this is known, the surgeon finds it easy to navigate and remove the lesion. And it's not just enough for the surface to be mapped. We also need to map the depth. So we use what is called subcortical mapping. So surgeon uses a special stimulator, a suction probe, which also delivers electric current, and during that time we look for responses. So whenever we stimulate the cortex, we will have to make sure that we don't give too much current. One, it should not cause current spread. Number two, it should not produce a seizure. So whenever we stimulate and look for EMG responses, we also need to record electrocorticogram from the brain. So whenever we see spikes at a particular current, we don't go beyond that current. We try to reduce and identify the threshold. So we use subcortical mapping to guide resection. And another interesting scenario is language mapping. Very interesting phenomena are here, but unfortunately since the video is not playing, I cannot show you. So on table the patient is awake, and if we deliver current to the right areas, we can produce a transient functional interruption, which immediately causes speech arrest or the phenomenon of anomia. So where the patient will be able to describe what object it is, but you won't be able to tell the name. So he will be speaking. It's not a complete speech arrest. So that also can be demonstrated. And another interesting phenomenon that we found is that in this patient, says terms that are phonemically similar to the word that she's supposed to say, but she creates neologisms. So these are interesting phenomena. Unless we go in, even neurosurgeons and neurologists don't know or haven't seen these phenomena. So it opens up a lot of possibilities, and once we demonstrate these things, surgeon gets the trust. So another case of speech arrest. So another special technique that's used in case of intramedullary spinal cord tumors is direct recording from the spinal cord. So we use special type of catheter type of electrode just under the dura over the spinal cord, and we record the descending volley of neural firing directly from the cord, and that helps the surgeon. So it's like an ECG. Just like how ECG comes from the heart, we can continuously, every second we get a response, D wave response, and whenever there is a change, drop in the amplitude of the signal, we know that the surgeon is causing a damage. So this is a 3-contact D wave, and a fancy thing, so just thought of. So another common tumor for which neuromonitoring is required is tumors around the cauda equina. Cauda equina is the nervous structure which provides innervation to the bowel, bladder and the lower limbs. So whenever tumor is there, it becomes very troublesome. So surgeon has to identify whether a given structure is neural element or not. If it is a neural element, whether it's functional or not. So probe is given, he stimulates, and we look for triggered EMG responses. And another advanced technique is bulbocavernous reflex testing. So here it looks at the entire arc. If you just stimulate and get response from sphincters, it just sees the motor efferent pathway. But if you do this stimulation, it assesses the entire arc. So even a sensory denervation of the bowel and bladder can be predicted intraoperatively by using this particular test. So we either stimulate the penis or the clitoris, as the case may be, and get a response from the anal sphincter. So these are some of the illustrative cases that I wanted to show, this short period of time. Now I'll talk about how the practice model is in the West. So owing to the complexity, as you would have seen from the previous slides, it is considered as an established specialty in the West. So there are consultants who get special credentials for performing intraoperative monitoring, and they have their trainees, and there are board certified technologists as well. So they run the system, and because there is a demand supply mismatch even in the West, this remote monitoring is quite common there. So which means a neurophysiologist sits in his cabin, and for about 5 to 10 surgeries of data comes to his screen, and then he tells the technologist there as to what to do. So that's remote monitoring. While that is the case in the West, in India there are a lot of challenges, as has been explained by Dr. Tripath. So the problems are similar. There is paucity of the number of trained specialists, and there is lack of structured programs, and there is no legislation as to who must be doing this. So that also is another problem. And these have always been problems with respect to other specialties as well. Like when they evolved new, they went through the same process. So it's not something unique to only us. And limited awareness among surgeons, probably 5 to 6 years when I started, there was limited awareness. But now the awareness level is much more than our physiologists, because they talk among themselves quite often. So in the last 5-6 years, they know more. They are well versed with the latest updates and things like that, and limited exposure also, it's picking up. They are quite conducive to allow intraoperative monitoring to take place. As long as the surgical outcome is good, as long as their patients are coming out well, they will be happy to support. And tech only model is also getting replaced. People are now looking into a physician taking care of neuromonitoring. Now, the only way to advance this field is through education. Now, I have put 2014-15, but neuromonitoring was started by Dr. Ashok in the year 2009-10. So when I was doing senior residency, he was actually a one-man army. So for 5 years, without the help of any resident, without the help of any technologist, he has been running the show. And that was very inspiring. And I had the opportunity and privilege of working with him for 1.5 years with him. And I was able to understand the process that he goes through, and I was able to copy that. And that actually made me, pursue this career. So Sir has been telling about taking that leap of faith. We didn't actually take the leap of faith. He was the one behind us and pushing it. so that's how it happened. And without much recognition, he was doing. CME started, dedicated CME started from 2014-15. But prior to that, he used to present in surgical conferences. So it will be a orthopedic spine conference. He'll be invited as a speaker. He'll be doing a session on it. He'll be traveling abroad and doing a live surgery and things like that. So that has happened even before 2014-15. But in India, no dedicated neuromonitoring CME or workshop has happened. It started only by 2000. But once it started, there have been 3 international conferences. We have represented our work in multiple international conferences. And Sir has made it a system in AIMS. And now about half a dozen MDs have these skills. And from my part, I have trained a CNIM qualified technologist. CNIM is a US degree for intraoperative monitoring, quite a tough exam. So my assistant is now having this certification. So with respect to legislation, as of now, there is no guideline or law that is actually regulating the practice of neuromonitoring. And it's now presently surgeon's discretion as to whether he incorporates IONM or not. It's not that if a CP angle happens or intramedullary tumor happens, you as a physiologist can go and ask, why are you not doing monitoring? Right now it is his discretion. But when law comes, things will change. If the surgeon is forced to do under monitoring, you will naturally look for people who could do that. So, and no professional organization, it's quite understandable. And as of now, the practitioners are too less and also not very keen. We should at least have 10 to 20 practitioners to form this thing. One good thing that has come up, a silver lining in the latest this thing is that insurance companies have started recognizing neuromonitoring as a separate billable entity. Now this is very crucial because going forward, there will be discussion and debate on if people are billing, who's doing it? What are the medical legal issues? And once that starts, we will have, that will help our cause actually. And if you are a beginner or if you want to start neuromonitoring in your center, you should know this. So if you want to set it up in your center, you should know for which surgeries acceptance is high for neuromonitoring. So among them, CP angle tumors, spinal cord dysraphisms, intramedullary tumors, conus cauda tumors, deformity spine, these have high acceptance. So if you like to start, you should know which surgeon is actually specializing in these and then talk to them. Educate, prime them, and then he will give it a try. If it works, if he likes it, probably he'll do more. And this has been our philosophy. Even Dr. Ashok sir is the one who seeded this philosophy in us. It should be organic growth. So we should not go and force it down the throat of a surgeon or or anybody that you should start neuromonitoring. So wherever you are, wherever you go, you will go through these phases. Surgeon will initially say, I've been doing this for 30-40 years, senior surgeon. I have not been doing monitoring. Why should I do now? And then, okay, many people are doing, his peers are doing. Next you will be like, okay, let's get the equipment, let's get it done. Then once the equipment will be there, this has happened in AIMS also, CTVS got the machine, 3 years it was lying. They were not using, and then they came and requested Ashok sir, and then something started with respect to CTVS. So if they have the machine, they'll consider that they will use the company person or EEG technicians. Then they'll realize it doesn't work like that, because they will face false alarms. False alarm is one where the one sitting within the system will say everything is all right, but at the end of the surgery, patient won't be able to move. That's the worst case scenario. So you are actually misguiding the surgeon to do a wrong procedure or take a wrong course during surgery. So that's not acceptable at all, and only then they'll turn towards a neurophysiologist. So whoever you are, even if you get the best neurophysiologist in the entire world and bring them to India, and if he starts a practice, you'll have to go through this. And
known as organic growth.
yeah, sir. So
Dr.
this has been,
Nishant, I'm sorry, I'll have
just
to request
2 more
you to,
minutes and then I'll stop.
please wrap up.
Yeah. So
thank
this has been our work so far. We've started. We are now able to not only cater to our center, we are able to cater to other centers as well. And this is the way forward. We need to identify and accredit neurophysiologists for practicing advanced neuromonitoring and form some kind of a national body and accredit training centers and evolve standards of neuromonitoring practice with respect to the Indian context and start training programs for MDs and certification program for technologists and propose to NMC if it works out for super specialty recognition. So right now, for you to do a good neuromonitoring, you need this combination: a good surgeon, billing surgeon, trained and knowledgeable physiologist, cooperative anesthetist, it's extremely important, the right equipment, and a professional administration which actually gives it the due credit. It should not be like you're going, doing, but if you don't get anything, then, then there's no point. So this, so if you start practicing, what next? So you can also take up entrepreneurship. So I got my own equipment, looking at the demand, and as I speak, the neuromonitoring equipment is at home. So I got my own equipment and I started, giving a service to other centers, and people got to know this is the order from ESI Hyderabad. So ESI Hyderabad has a collaboration with my firm. I mean, it's supposed to, Zoom and show, but it's not showing. So this is the, so if you take up entrepreneurship, it's not necessary that you have to restrict to private hospitals. You can also provide service to government hospitals. This being ESI makes it more significant. I mean, this was the order that came about a year back. So we've been giving this service for about a year. And if you are someone, I mean, the conventional physiology career, with all due respect to it, I mean, it's great. But if you are someone who's not happy with your current situation, or you want to challenge the status quo, you can venture into neuromonitoring. Of course, you have to have certain soft skills. You need to work on your soft skills. Two important thing is conscientiousness. That means how organized you are, how sincere you are, how dependable you are, and agreeableness. Agreeableness does not mean you agree to everything, but you don't antagonize, right? So one incident happens, and if you are not agreeable, then you won't get in good terms with the surgeon, and you won't be able to go to the OT next time. So you need to work on soft skills, and right now these are the opportunities available in India. So this is from my personal experience. In India, you can work in private hospitals. There are plenty of neuromonitoring companies, venture capitalists from the US who have invested. They are looking for physiologists, but they don't get. Or you can become an entrepreneur by investing on your own, get an equipment on your own, and provide service. You can be a freelancer, and you can also work in academia and government institutes. Right now, PGI wants a neurophysiologist, NIMHANS wants a neurophysiologist. Faculties got in touch with me. Unfortunately, I don't have people to refer. So, and abroad opportunities, there are programs for MDs, overseas MDs in the West. In US, it's very common. So if you have a decent exposure to neuromonitoring, you can crack and get a fellowship there. And there are also neuromonitoring companies there. If your work is recognized, they can call you and give a visa and make you work there. And there is a UK. See, whenever I talk about West, it means only US. In UK, neuromonitoring is as bad as in India, if not worse. In fact, it's worse. They have a recognized clinical neurophysiology specialty, but none of the neurophysiologists, even the topmost, they are into neuromonitoring because they are doing their routine work, and for reimbursements NHS has to agree. NHS is like a government system. So I did a kind of a needs assessment. There are roughly about 2,000 centers which want neuromonitoring right now, but as of now only 160 installations are there. So there is a huge scope for growth. And MD physiologists are the right candidates because of our background in research, academia, electrophysiology, experimentation, and the fact that we don't have anything else to do. Because as in when compared to a neurosurgeon taking it up, neuroanesthetist taking up, or other clinicians taking it up, this will be our prime. This can be our prime interest. To conclude, neuromonitoring skills can catapult MD physiologists into realms outside teaching and laboratories. So it can shift the paradigm from laboratories to operating theaters, and your audience could change from undergraduates to specialist surgeons. And it's novel, challenging, it is meaningful, and it does provide stable and sustainable career pathway. Take it from me, I have not been associated with the physiology department for the last 5 years. I tried to manage both, it doesn't work. So after 2 years, I left the physiology department doing only neuromonitoring. And neurophysiological decision making has a direct impact on surgical course and patient outcomes. So if you make the right call, you can be satisfied at the end of the day. And so it also gives an opportunity to work on the frontiers of neuroscience. Like there are advanced techniques, you can stimulate the cerebellum, you can create in an intraoperative model of cerebral mutism during surgery, and plenty of things are coming up. So if you are into research, you can also delve into that. So with that, I'd like to conclude. That's my
Thank
team
you so
in
much.
Chennai. And these are the acknowledgements.
Thank you, Dr. Nishant. As always, a very comprehensive overview of IONM. I do wish the videos would have run, it would have made it more interesting.
But we would not have finished on time, so it's good.
Yeah, then we would have cut short the other stuff.
Some mystery should remain, so we ask and search for it.
For your next talk, I think it will work out.
Yeah.
And thank you again. Any questions now? We are open to the questions now for both Dr. Tripat.
Just 10 seconds. मुझे ये जानना है, after knowing so much of IONM, that is you have given a very nice professor. What are the future perspectives?
So future perspectives is what we make out of it. As I said, right now it all boils down to individual interest. Now because of my interest, I'm going to other centers. Because of Sir's interest, he has created a setup in AIMS. He is training people. Now we need more people.
My question is, are we having any career out of it?
Yes. So I've been working as a neurophysiologist for the last.
Thank you, Dr. Jyoti. Thank you, Dr. Nishant, once again.
Thank you once again, Dr. Pandey and Dr. Ashok, for a very, very fruitful, invoking session, because this should not be the end, but the beginning to learn more about it. And thank you, Dr. Tripat and Mrinal. So we are closing this session now. Thank you.
Felicitation.
Thank you very much, Chairpersons. We will now move to the main hall for the.
I request all the dignitaries who have logged in, please log in to Dhanvantari Hall. We are moving the sessions there now. Yes, sir. Yes. And thank you, ma'am, for conducting the session so beautifully, and thank you to all the speakers for enlightening us. Thank you all others to have a patient ear. I now request our chairpersons, Dr. K.P. Kochar and Dr. Renuka Sharma, to kindly felicitate the speakers. Dr. Mrunal Pathak and Dr. Hansraj. Dr. Mrunal Pathak, ma'am, can you please be connected? Stay connected with us for the felicitation. Okay. Dr. Ashok Kumar Jaryal. Dr. Tripat Deep Singh. Dr. Nishant Sampath. I now take the opportunity to call Dr. Asha Gandhi to please felicitate our chairpersons. Ma'am, can you please come? Dr. Asha Gandhi is a renowned academician and HOD of Physiology Department at SGT University. Ma'am has more than 50 publications to her credit and is a recipient of Health and Education Development Award, Sri Satyapal Sabharwal Award, and also earned Lifetime Achievement Award in recognition for her distinguished services to LHMC. I now request everyone to please move to Dhanvantri Hall, and everyone connected with us online kindly log into Dhanvantri Hall. We will be continuing our sessions over there.
What happened here? Why it was not working? It has never happened. नहीं वो ये है ना This is whose laptop? This is whose laptop? ये किसका लैपटॉप है? आप प्रोजेक्ट आप प्रोजेक्शन नहीं मैं आप कौन पूछ रहा हूँ मतलब प्रोजेक्शनिस्ट ओके
Very good afternoon to one and all. A very warm welcome to all online and offline dignitaries, distinguished chairperson, participants, faculty to this wonderful afternoon session of Day 2 Epicon 2022. It is my immense pleasure to be here and I hope that we'll all have a great session ahead. Starting with this session, the first event of this session is free paper presentation. And to chair this session, we have Dr. Avinash Ingle. Sir, please take it. Dr. Avinash Ingle is an additional professor at AIMS Raipur. He has a 6.5-year experience as an intensivist in ICU. He has received Best Award for the Best Paper Presentation at Singapore Prevention and Cardiac Rehabilitation Symposium by World Health Heart Federation. He has done various projects on yoga-based lifestyle changes, various online surveys on medical practitioner and school-going children. We welcome you, sir. Next, the next judges of the free paper presentation is Dr. Pradeep Barde. Dr. Pradeep Barde is an associate professor in physiology in AIMS Rajkot with interest in development in medical devices. He has intentional patent in medical devices, developed indigenous high altitude hypoxia simulator and has a various publication to his credit. He is currently involved in extramurally funded research project by DST Satyam, which involves studying the effect of various mind-body relaxation technique of health of COVID-19 healthcare workers at the Department of Physiology in AIMS Rajkot. We welcome you, sir. Now, the first speaker of this session is Dr. Pooja Ojha. Her title of presentation is The Alpha Rhythm Characteristics in Migraine. During ICTAL phase, do brain maps have a role in identification? We welcome you, ma'am.
Good afternoon, respected judges, one and all present here. I will be presenting my work on alpha rhythm characteristics in migraine during ictal phase. And we have also looked into the role of the brain maps in this context. So, migraine, as we know, it's a very common headache disorder, and it is the 6th most disabling disorder which is labeled by the World Health Organization. It may lead to the fluctuating neuronal dysfunctions, and it can affect the brain rhythms. Migraine patients have also been found to have alteration in the low-level perceptual processing of information. And in this context, alpha oscillations, they are suggested to control the timing of perceptual process. Moreover, the alpha oscillations, they may be related to the disease severity, because it has been found that increased risk of the subclinical white matter lesions in patients with migraine has a bearing on the alpha oscillations. So, quantitative EEG is being increasingly used to study this, study the changes in brain rhythms in patients with migraine. And the most important finding, or the primary EEG finding of cerebral ischemia, it has revealed low alpha activity in the overlying electrodes. So therefore, it is of interest to look into the alpha rhythm characteristics in the resting state migraine. So by resting state, I mean that there is no activation being given. Person is not being asked to do any task. So we hypothesize that the alpha rhythm changes, they can be observed in the migraine using the quantitative EEG, and the disease severity of the headache would be associated with the changes in the alpha rhythm. So with this, study was planned with the objective to ascertain the resting state alpha rhythm characteristics in migraine through frequency band power and estimate its correlation with the disease severity. So we planned a case control study in which we enrolled male and female patients in the age group of 20 to 40 years who were diagnosed with common migraine according to the International Classification of Headache Disorders, 3rd edition. And anybody who was having headache which was other than migraine, having chronic medical illness, neurological or psychiatric comorbidities were excluded from the study. And we selected the controls among the other patients who were in the, among the relatives of the patients, but the important point was that they should not be having family history of migraine, and they were in the same age and gender matched. The study was approved by the Institutional Ethics Committee, and written informed consent was obtained from all the participants. So we inquired about the frequency of headache, duration, and severity, which was taken on a 0 to 10 numeric pain scale rating, where 0 was no pain and 10 was the maximum pain which was there. So the patients were instructed, all the participants were instructed to lie still with eyes closed, and electrodes were applied according to the 1020 international system. The data was collected from 19 channels in the eyes closed and relaxed state for 15 minutes. So after the data was collected, the raw signals were sampled at, they were sampled at 256 hertz, and they were stored. And later on, the data from the RMS EEG SuperSpec machine that was imported in the EDF format into the EEG lab toolbox for pre-processing and analysis. After the removal of the artifacts, re-referencing, the data was analyzed to derive the alpha rhythm characteristics. So we focused on the peak alpha frequency, that is between the highest frequency which was there between 8 to 13 hertz, that was considered the peak alpha frequency. Then absolute alpha power, that was the integral estimate of the total power which was there between 8 to 13 hertz. And also the relative alpha power, which was the percentage of how much alpha power is there is compared to the all other frequency bands. Then we used the t-test for comparison of the quantitative EEG parameters with between the migraineurs and controls, and we used the Pearson's correlation to estimate the association between the clinical features and the EEG parameters. So we found we had 45 participants. Out of them, 23 were healthy controls and 22 were the patients. 5 were men, 17 women were there. Their age and gender were comparable, as it was not, there was no statistical significantly difference in the age and gender of the two groups. So we found that the mean, the duration of headache was 33.5 hours. Then frequency of headache 9.1 per month. Severity was 7.2 on a scale of 0 to 10. 19 patients, that is 86% of them had photophobia, and 81% had phonophobia. So when we looked at the alpha rhythm characteristics in these patients, we found that there was a statistically significant difference in the alpha power in the frontocentral, temporal and the parieto-occipital regions, which was low as compared to that of the healthy controls. And when we looked at the occipital peak alpha frequency, it was found to be statistically significant. It was the peak alpha frequency was found to be low in the patients as compared to the control, and it also correlated with the disease severity. As you can see that as the severity of the disease has increased, the peak alpha frequency is decreasing. We also tried to look at what the brain maps can help us to differentiate, though it is a visual comparison, but does it have a role in it or not? So this shows the band power in different frequency bands, that is 0 to 4, 4 to 8, 8 to 12, 12 to 16. And we can see here that healthy control, that is A, and in the migraine patients, that is B. So we can look at the frequency between 8 to 12, that is alpha, and it can be seen that it is visually we can see that the alpha difference in the alpha band power in the two cases. So we have seen the literature, and we found that slow alpha band oscillation was also observed during attack by the other researchers, and Bijog and et al., they also found that there was an increase in the peak alpha power during the ictal phase. And peak alpha frequency has been reported to be slow in patients with more disease burden. So we concluded that the findings of this study support the existence of a neuronal dysfunction during the ictal phase, that is during the attack phase of the disease. Then alpha power variation exists at the time of ictal phase of migraine, and it correlates with the severity of the disease. Brain maps, they enable the pictorial representation of the power distribution over various regions of the brain among the headache patients, and they may have a role in, it needs to be further elucidated, but still it can be considered. Thank you. Sir, there could be effect of the patients who are taking drugs, like medications, that could have an effect on the brain waves. So we try to take in patients who were more naive, who were diagnosed recently, and long-term effect of drug could not be there, and otherwise we could not rule out the the diseases which could affect the brain rhythms. Those we have tried to exclude, put in the exclusion criteria, so that there is no effect of those drugs or medications or diseases on the brain waves.
So these patients were referred to you from the neurology or
Yes, sir.
medicine department?
Yes, sir. They were from the neurology department.
With the diagnosis?
Yes, sir, with the diagnosis.
So you rule out other the exclusion criteria by clinical investigation or by the history of
Sir, we had my co-author, Dr. Panda ma'am, is also there in the neurology department. She's part of the study. So patients were recruited from that neurology OPD, and they were only those which were following the inclusion and exclusion criteria.
So don't you think it can put in the bias into the subject selection?
There may be, but we are focusing on the changes in the brain rhythms, with particularly the alpha rhythm. So we may look into that.
When you say selection bias can be there? How we can take care of this? It's because clinically it is like something, the EEG will show something and something will come out. It is most important thing in this scenario, I feel personally, is the how you select the subject and putting them to a particular investigation and then analyzing it. So if I am the clinician who is diagnosing and I am putting and sending now, include this subject and don't include that, or we cannot include that. So do you think, as a scientist I am saying, what would be better choice?
If we are two people are in a study, they need to discuss the things, and then how it has to be selected. The patients, all those who need to be excluded, it has to be discussed and processed in that way.
How it can be done in a better way? It's a subject recruitment.
You need to say
different sampling methods, right?
Yes, yes.
My question is for sampling method. In this study, specifically clinical studies, how can you make it much better to avoid the selection bias?
To take a more larger sample and
Anything more than that?
I can't think of that.
What was your exclusion criteria?
So patients who were having chronic medical illness and psychiatric diseases,
Medical illness.
like diabetes.
Not having medicine. You said no, recently diagnosed.
No, for the migraine pain, for the medication of pain. That.
And average was 33 hours.
Yes, sir.
Total duration.
Yes, sir.
So they were off medication.
No, they were not off. That was the duration of pain. That was the average duration of the pain they were having, regarding the clinical history. So that was the duration of the pain.
What are the clinical implications of the study?
Sir, if we can learn more about how they perform in the task, or if something is given to them, like based upon the alpha rhythms, so that can be further assessed, putting them into perform some visual attention task or other kind of cognitive task, and then we can see how they are responding, or is there an alpha variability in them, because alpha variability is very important for perceptual information. I understand something based upon what my alpha variability is. So that can be further explored in these patients group.
As the one slide you showing during discussion, this has been already established, like 3 or 4 references you quoted.
So there are other who have not been able to find. There is a controversial thing like they have found the opposite thing, but their group of patients, their methodology may have been different to conclude.
Same can be in your case then.
Yes, maybe.
Right.
Our group of patients.
Yeah, please.
Exactly.
We have to look at the science with the open mindset. Either way, you have quoted only, I think, those references which were like echoing with your, but there are differences also. And
yes, right.
As a science with open arm, our purpose should not to prove ourselves, but prove the fact or disprove the fact. So it was a good attempt and good study. Thank you.
Thank you.
Our next speaker is Dr. Prashant Bhatnagar. He will be giving presentation. Any questions online? Online, any questions? No questions. So our next speaker is Dr. Prashant Bhatnagar. His topic of presentation is Impact of Listening to Classical Instrumental Music on Cholesterol Level in Indian Medical Student. Online. Dr. Prashant, can you hear me?
Yes, ma'am.
So please put your slide on your projector.
Yes, ma'am.
Hello, hello, hello.
Hello. Am I
Hello.
audible, ma'am?
Yes, ma'am. Yes, sir. Sorry. So before starting your presentation, I just want to notify that the presentation should be finished in 10 minutes, sir.
Yes, ma'am. Sure.
Thank you. So you can start your presentation.
Thank you, ma'am. Good afternoon, everyone. Myself, Prashant Bhatnagar, Assistant Professor, Department of Physiology at Rajkot Medical College, Jalandhar. Before starting my presentation, I would like to thank you all and all the organizer of the conference for providing me this opportunity. My topic of research paper is Impact of Listening to Classical Instrumental Music on Cholesterol Level in Indian Medical Students. As we know, Indian medical students come across various life-altering situations during their academics, whether it is transition from school life to college life, exposure to grave scenario, death, illness, along with their difficult syllabus to learn. Also, in Indian household, being a doctor is seen quite a noble profession, and every parent dream of having a doctor in the family. This again puts a lot of pressure on young mind, and they suffer with the stress, depression, and anxiety issues. Psychological stress can affect certain human organs and some important physiological parameters. It is known that blood lipid dysfunction are quite common in case of increasing mental stress and anxiety. When a person faces a stressful situation, they may experience hemoconcentration. The blood loses its fluid and the component of the blood become more concentrated, which include cholesterol as well. Thus, the cholesterol level rise up in a stressful situation. Music play a noteworthy part in relieving mind of its anguish. It is an easily attainable form of art and has an immediate effect on mind. Studies have found the therapeutic effects of classical music on stress and anxiety. Our aim of study is to qualitatively evaluate the effect of classical instrumental music using ADSS score and to qualitatively evaluate the effect of music on lipid profile, to evaluate the effectiveness of music therapy and see the changes it brings about in stressful lives of medical students. Methodology, it is an interventional study and study population 60 healthy 17 to 25-year age first year MBBS students of Rajkot Medical College, Jalandhar. Exclusion and inclusion criteria was study undergoing students undergoing some treatment, medication, overweight student who dislike music, having hearing impairment, and those suffering from excessive depressive disorders or anxiety were exempted from the study. Before starting the study, a written consent was taken from all the participants. An ADSS questionnaire designed by Dr. Pallavi Bhattnagar et al. Was filled and blood sample were taken by each participant before and after the music intervention. The ADSS questionnaire consisted of different questions related to anxiety, depression, and stress felt in day-to-day life. The response of each question was to be given in the form of yes and no. The score for each yes was counted as 1, and for every no, the score was 0. The lipid profile was analyzed by a standard method for each blood sample in the Department of Biochemistry of the institution using auto analyzer. Music intervention. The music therapy began at 8 a.m. in the morning in properly ventilated and isolated study hall in the institution. The subjects were asked to relax while sitting on their respective seat and keep their eyes closed while listening to the music. The Indian classical instrumental music Raga Desi Todi by the famed musician Pandit Hari Prasad Chaurasia was played for the next half an hour at 50 to 60 decibel. This procedure continued in the same manner for 1 month. Subjects were asked to feel comfortable in approaching in case of any discomfort felt during the therapy. The ADSS questionnaire was refilled by the subject after 1 month of music therapy. Blood samples were collected and serum cholesterol was measured again after the 1 month long therapy. All the statistical data were studied and assembled using SPSS 21st version software by IBM. The student's pair t-test was implemented to differentiate between value obtained before and after the musical intervention. A p-value less than 0.05 was considered to be the significant value. This is the observation table and result. The table 1 shows the comparison of before music therapy and after music therapy of ADSS questionnaire score. For anxiety, p-value was 0.002. Before the music therapy, mean and ST was 6.08 plus minus 2.03, and after the music therapy it was 5.55 plus minus 1.36. For depression, p-value was 0.001, and for stress, p-value was 0.002. Before the music therapy, mean ST for depression was 5.87 plus minus 1.2, and after the music therapy it was 5.55 plus minus 1.11. For stress, mean and SD was 6.82 plus minus 1.75, and after the music therapy it was 6.67 plus minus 1.6. The p-value indicates there was a significant difference in anxiety, depression, and stress after 1 month long music therapy. Table 2 shows the comparison between before music therapy and after music therapy for the lipid profile. For triglyceride, p-value was 0.014, and for HDL, p-value was 0.009. For LDL, p-value was 0.001, and for total cholesterol, p-value was 0.003. It shows the significant difference for the p-value shows the significant difference for triglyceride, HDL, LDL, and total cholesterol. Conclusion, result of current study shows that there was a significant decrease in anxiety, depression, and stress level of the student followed music therapy of 1 month. It was seen that ADSS score value varied greatly after the subject went through music therapy. The new response was found to be more positive as compared to the previous response to the questions in the questionnaire. Moreover, there were a significant decrease in lipid profile of these students. It was found that the level of triglyceride, LDL, total cholesterol reduced, whereas the value of HDL increased after the music therapy using Indian classical instrumental music. The result of present study advocates the positive effect of using Indian classical instrumental music on the serum cholesterol value of stressed Indian medical students. However, more studies are recommended taking larger population in order to make a general policy for the betterment of medical students. This is the format of my questionnaire. These are the references. Thank you.
Thank you, Dr. Prashant. Any questions, online, offline? Can you hear, Dr. Prashant?
Yes, ma'am.
Dr. Prashant?
Yes, sir.
Okay. You had selected means, students
Yes, sir.
from who are actually in first year.
Yes, sir.
So you are teacher for them.
Yes, sir.
And you have you taken the IEC consent?
Yes, sir.
Was there any issue?
No, sir,
There
no.
should be. There should be, because those are means actually they are performing under you.
Yes, sir.
And how was the blinding? Hello.
Yes, sir. Sir, I have
Was it
taken the, I think,
open feedback or a closed feedback?
sir, open feedback, sir. Actually, sir, the students, they are willing to participate in the study. I have taken the consent, and
Yeah.
I told them all the, sir, procedure which we are going to follow during the study and after the study. So I have taken the consent from them.
So what was the reason for not taking closed feedback?
Sir, they are free to they are free to approach me if it is a close feedback. They may be not able to share all the things they are feeling, whatever they are feeling during the study.
And one more thing, in patient information sheet,
yes, sir,
you might have informed them, I mean, or asked them whether really they like the classical music or not. If someone doesn't like, and if you are asking them to listen same music for a long time, that itself can cause the stress.
Sir, in the exclusion criteria, sir, just we have asked the subjects whether they like the music or not. If they are not like, we excluded them from the study, sir.
How can you say that the cholesterol reduction, whatever significance it showed,
Yes,
was
sir.
only due to the classical music and nothing due to else?
Sir, actually, we have taken the all the parameters from them. Like previously, we did not rely on the blood test. We have taken the ADSS questionnaire also as a reference. So previously, they are in stress, and after 1 month music therapy, they respond for the ADSS questionnaire very well. And for that, we can conclude that the stress come down, and the as well as the lipid profile, cholesterol levels.
That is the parallel measurement, two domain that you have done. One is psychological assessment and one is biochemistry.
Yes,
I'm
sir.
talking about, like, can anything else can cause same effect without listening to music as well?
Sir, that
How
might
can
be,
you how can you do a better study design to rule out that this question that I have asked?
sir, dietary history also can be considered, sir, for this. Dietary
Okay.
intake.
Okay. Anything else? In study design, can you do some changes? Or could have been done?
Sir, not in my mind, sir. Yes, right now.
And why you selected the particular raga?
Sir,
Who decided?
actually, sir, in Indian culture, we have different kind of music, and they shows the different effect on human body. And raga could be particularly known for the therapeutic effect on stress and anxiety, sir.
Okay. So, based on the literature you are talking about, or it is just known in general perception?
Sir, according to sir literature.
Okay. Okay.
Thank you, sir.
Thank you, Dr. Prashant.
Just a minute. Hello.
Yes, sir.
Hello. Was there some questionnaire about the physical activity during this period?
No, sir.
Then might be they have increased the physical activity or started some new physical activity also, or might be there were some sports events in between.
No, sir. Actually, I have taken, like we excluded if they are under any treatment or they are doing yoga or something else, we exclude that students from the study. If they are
So
doing
how you
yoga,
control those activities?
yes, sir.
Nothing is mentioned, but how you controlled those activities?
No, actually, sir, we have not controlled. We just ask the subjects, like if they are under any complementary and alternative medicine, like meditation, like yoga or something they are doing, we excluded them.
Okay, thanks. Any question from audience?
Any question online, offline? No? Thank you, Dr. Prashant.
Thank you, ma'am.
Our next speaker is Dr. Priyanka Garg. Dr. Prashant,
Yes, ma'am.
can you hear us?
Yes, ma'am.
Dr. Prashant,
Yes, ma'am.
did you hear the question, sir?
No, ma'am. No, ma'am.
No, no.
Hello?
Sir, can you hear now?
Yeah, yeah.
No. Loud and
Yes,
clear?
ma'am. Yes, ma'am.
Okay.
Hello? 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 Can
Yes,
you hear me,
ma'am.
sir?
Yes, yes, ma'am.
Okay. Okay, sir, I wanted to ask whether the changes that you saw, was there anything in the study design that would indicate that this was due to the long-term effect of your intervention, or could it be possible that these effects were due to the acute effect of the very last session that they had received?
Ma'am, it is after 1 month only we have taken the sample, ma'am.
Yes, yes. Okay, thank you very much.
Thank you, ma'am.
Thank you, Dr. Prashant. Our next speaker is Dr. Priyanka Garg. Hello, ma'am. Dr. Priyanka? Her title of presentation is Assessment of Endothelial Functions in Different Form of Hypertensive Disorders in Pregnancy. Priyanka Garg. Dr. Priyanka? Hello?
Yes. Can you hear me? Can you hear me?
Dr. Priyanka?
Am I audible? Am I audible?
Little louder, ma'am.
Just Am I audible now?
Now, ma'am, better, ma'am, better.
Okay.
Ma'am, you can start your presentation.
Okay, okay. Thank you. So, good afternoon, all of you. Myself, Dr. Priyanka Garg, working as Assistant Professor in the Department of Physiology at Rani Durgavati Medical College, Banda, UP. I have done my PhD from AIIMS New Delhi. So, the work which I am presenting today is a part of that study. So, the title of my presentation is Assessment of Endothelial Functions in Different Forms of Hypertensive Disorders of Pregnancy. Now, the hypertensive disorders of pregnancy are a global concern and are the major cause of maternal and fetal morbidity and mortality worldwide. Hypertension during pregnancy mainly includes gestational hypertension and preeclampsia. Gestational hypertension is a condition where blood pressure is more than 140 by 90 mm mercury after 20 weeks of gestation, while preeclampsia is defined as the new onset persistent hypertension after 20 weeks of gestation in association with significant proteinuria. Globally, 5 to 8% of all pregnant women are affected by pregnancy-induced hypertensive disorders, while in India, the incidence is around 10%. The common causes of pregnancy-induced hypertension are nulliparity, multiple pregnancy, family history of pregnancy-induced hypertension, or history of diabetes, hypertension, or renal disease, etc. Now, pregnancy-induced hypertension can result in various maternal and fetal complications. The impact of hypertension in pregnancy is severe because of its unknown etiology and unpredictable nature. The previous reports have indicated that gestational hypertension and preeclampsia are a disorder of widespread vascular malfunction and associated with the increased cardiovascular risk later in life. When we reviewed the flow mediated dilatation, we could find only one report where they have assessed it from first to third trimester of pregnancy. Here, asterisk sign in this table, the asterisk sign alone indicates the studies with single time point measurement, while asterisk sign with arrow indicates the prospective study. So as we can see from the table, there was only single report where the endothelial function, which can be assessed by flow mediated dilatation, was measured from first to third trimester or even postpartum period. And additionally, in this longitudinal report, they have not assessed in gestational hypertension and in preeclampsia patients. So therefore, the aim of the present study was to assess the endothelial functions in different forms of hypertensive disorder, and especially the preeclampsia and gestational hypertension of pregnancy. So this was a prospective observational study, and all pregnant women were in their first trimester between the age of 18 to 35 years, attending the antenatal clinic of the Department of Obs and Gynae at AIIMS New Delhi were recruited, and written informed consent was taken from all the women. However, women with chronic hypertension, renal disease, autoimmune disorder, anemia, or any other known vascular disorder, pre-existing diabetes mellitus, or multiple pregnancy were excluded from the study. Now, endothelial function were assessed at 3 time points over the course of pregnancy. Visit 1 was at 11 to 13 weeks, visit 2 was at 20 to 20 weeks of gestation, and visit 3 was at the 30 to 32 weeks of gestation. Endothelial functions were assessed by flow mediated dilatation using vascular ultrasound. In this technique, a blood pressure cuff was placed below the elbow on the forearm, and the ultrasound probe was placed above the cuff, and lead 2 ECG was simultaneously changes with cardiac cycle. After collection for baseline data, arterial blood flow was occluded by rapid inflation of cuff to 50 millimeter of mercury above the systolic blood pressure, and occlusion was maintained for 5 minutes. After release of occlusion, artery diameter was measured for 3 minutes at every 10-second interval. Then FMD percent was calculated by using formula peak diameter minus baseline upon baseline diameter into 100. Because flow mediated dilatation is dependent on the baseline artery diameter, therefore the FMD was normalized for baseline artery diameter at each trimester, and normalized FMD was calculated as FMD percent upon baseline artery diameter. So now coming to the patient recruitment details, a total of 256 pregnant women were recruited in their first trimester before 14 weeks of gestation, and out of which 208 women were completed all the 3 visits. Rest were excluded from the study due to various reasons. Now, out of those 208 women, 34 women developed hypertension during the over the course of pregnancy later in over the course of pregnancy. Now, out of those 34 hypertensive women, 21 developed gestational hypertension, and 13 women developed preeclampsia later in pregnancy. Out of remained healthy, while rest were gestational diabetes mellitus, hypothyroid, anemia, and other. But for the purpose of analysis in the present study, data of 34 hypertensive women, out of which 21 were gestational hypertension and 13 were preeclampsia, and 60 age-matched healthy pregnant women were used for analysis. So there were total 4 groups: healthy pregnant group, gestational hypertension group, preeclampsia group, and one group was preeclampsia plus gestational hypertension, or we can say the overall group. overall hypertensive group. All groups were comparable in terms of age, while BMI was significantly higher, eclampsia plus gestational hypertension group than healthy pregnant group. Gestational age at delivery and the fetal weight both were significantly lower in preeclampsia and preeclampsia plus gestational hypertension group than healthy pregnant group. Now, as we can see from the graphs that the BP was significantly higher, that was as expected in all the three groups of hypertension than healthy pregnant group, starting from first trimester to third trimester of pregnancy. No significant difference was observed in BP among three hypertension group.
Excuse me, ma'am. Dr. Priyanka?
Mid-trimester drop was observed in all the groups. However, coming to the flow-mediated dilatation, end of fall in all the groups.
Sorry to interrupt, ma'am. You have only 1 minute to wind up.
Significant in preeclampsia group and preeclampsia gestation prevention group from first to second and first to third trimester of pregnancy. On intergroup comparison, FMD was lower of pregnancy, although it was non-significant. And similar results were obtained for FMD when we normalized to baseline artery diameter. However, normalized FMD was significantly lower in preeclampsia group than healthy pregnant group at second and third trimester of pregnancy. So this decrease in FMD, which we found in healthy pregnant maternal inflammatory response on late gestation on nitric oxide dependent vasodilatation, and an abnormality in nitric oxide synthesis or action could be responsible for the endothelial dysfunction, which we observed in women who subsequently develop hypertension over the course of pregnancy. The pregnancy study suggests that hypertension during pregnancy is associated with the endothelial dysfunction, and compromised endothelial functions were noticeable from second trimester of pregnancy, that is before the development of preeclampsia or gestational hypertension. Thank you.
Sir, any questions, sir? Ma'am, are you audible, ma'am? Can you hear us? Dr. Priyanka?
Yes, I can hear.
Okay.
Yes, I can hear.
Yeah, very good study. Regarding the technique of flow-mediated dilatation based on the ultrasound, how do you see, considering its subjectivity versus objectivity of the measurement, what it is measuring? Because you are using it.
I couldn't hear properly.
Yeah, any measurement device or any device that you use on human body, it measure with certain principles. So principle of ultrasound are user specified. So who did the measurement, and how you ensured that that variability,
Yes,
subjective variability, is not there?
Yes, sir. Actually, the measurement were performed itself, that is preeclampsia or gestational hypertension later. Means as soon as the data was
Ma'am, your voice is breaking, ma'am. Dr. Priyanka? Dr. Priyanka? I think some technical delay, I think.
Yes.
We'll start our next presentation. Our next speaker is Dr. Ritu Roy. Neetu Roy.
Yeah, Neetu Roy.
Her topic of presentation is knowledge, attitude and perception and apprehension of medical student of medical college in Delhi NCR. Ma'am, you can start your presentation.
Thank you.
Ma'am, you will be given 8 minutes
Oh, yeah,
for
sure.
presentation.
Okay. Very good afternoon to all. I'm Dr. Neetu Roy. I'm assistant professor in the Department of Physiology, Rama Medical College and Hospital, Hapur. My topic of presentation is ATCOM, knowledge, attitude, perceptions, and apprehensions of medical students. There are increased incidents of violence against doctors, and one of the reasons which is considered behind this violence is the poor communication between the doctor and the patient. So it is thought that Eve will improve the communication skills of the doctors. So that's going to improve the doctor-patient relationship, and that will certainly reduce the violence against doctors. So NMC introduced the model of ATCOM, that is attitude, ethics, and communications, as a structured longitudinal program in new medical curriculum from 2019 batch. This entire concept of ATCOM module that lies on the fundamental principle that changing a person's attitude will change his or her behavior, and behavioral change will surely inculcate soft skills and will improve the person's communication skills. And that's going to benefit in maintaining the doctor-patient relationship. With this, the aim of my study was to assess the knowledge, attitude, perceptions, and apprehensions of first-year medical students after completion of first phase of ATCOM module by using a semi-structured questionnaire. And objectives were to assess the first-year medical students' knowledge and attitude. That was the first objective. Second was to assess the perceptions and apprehensions of students related to ATCOM. Inclusion criteria: all the first-year medical students after completion of first phase of teaching ATCOM modules. First year is having 5 modules of ATCOM. So after completion of all those 5 modules, students were included in this study. And the place of study was the Rama Medical College and Hospital, Hapur. Before that, institutional ethical clearance was taken. A self-administered, semi-structured questionnaire was given with informed consent to assess their knowledge and perceptions. And this questionnaire was semi-structured, had both closed and open-ended questions. Assessment was done by recording their reflections and feedback. And all the modules of ATCOM were assessed through competencies. It was taught by lecture, role play, interactions with simulated and real patients in clinical settings and case studies. All the 5 modules were assessed by using both open-ended and the closed-ended questions. Knowledge and attitude was assessed by evaluating them for competencies for each module, different modules that is being taught in the first phase of the MBBS. Students' apprehensions were also recorded by using open-ended questions. Result was, it was a descriptive analysis and was done by using SPSS 20 software. Competency evaluation was done for all the students, for all 150 students. But the questionnaire was also given to 150 students, only 140 students completed the questionnaire. And in competency evaluation, the result was that more than 90% students were able to meet expectations, and all of them were interested in using ATCOM modules in their clinical practice. They all had positive attitude towards ATCOM modules. More than 80% students believe that ATCOM will improve their communication skills and it will help in building good doctor-patient relationship. There are 5 competencies which are in the first phase. So there are 5 modules. So these competencies for which we evaluated the students were also related with these modules only. The first was that they are able to demonstrate respect and follow the correct procedure when handling cadaver, identifies physician's role and responsibility to society, demonstrate ability to communicate to patients in a respectful and empathetic manner, demonstrate a commitment to continued learning, communicate diagnostic and therapeutic options to patients and family in a simulated environment. These were the competencies which were students were subjected to and were categorized into a scale, that is meet expectations, does not meet expectations. For the first one, that is demonstrates respects and follow the correct procedure when handling cadaver. So 135 students were like they meet expectations except 15 who were not able to meet up to the expectations. Identifies physician's role and responsibility to society, 130 students meet expectations. Demonstrate ability to communicate to patients, 132 students meet expectations. And the last one, that was demonstrate the commitment to the continued learning, communicate diagnostic and therapeutic options to patients and family in a simulated environment. That was 120 students meet expectations. So this is how we evaluated the competencies, their knowledge and attitude. And for evaluating the perceptions and the apprehensions, we used a questionnaire. That questionnaire was a self-administered and semi-structured, having both closed and open questions. So the closed-ended questions were these were the questions, and the responses were these are the number of the students, and was reported in 3 scales: yes, no, and not sure. So the first one was ADCOM will be, the question that was asked was the ADCOM will be taught as longitudinal program. Are you aware that it will be taught as longitudinal program in different pages? So 140, almost all the students were aware of that it is going to be taught in a longitudinal manner. And the second question that we asked was, do you feel ADCOM teaching will improve your soft skills? 120 said yes, 15 were not sure. You will deal with your patients with more empathy. Yes, there's almost 100% students were active with this fact that yes, they are going to deal with their patients with more empathy after having ADCOM modules, after teaching these ADCOM modules. Your communication skill will improve, soft skills will improve. Yes, they say 120 students say yes, 15 were not sure, 5 were no. Do you know the rights and duties of a patient? Do you know the right and duties of a doctor? So 110 patients agreed that yes, they know about, they're aware of the rights and duties of patients. They're aware of the right and duties of a doctor. Do you feel improved doctor-patient relationship will reduce violence against doctors? So the 30 students they were not sure about this fact, whether it will improve or not. But 90 were yes, it will improve the doctor-patient relationships. Open-ended questions were also asked. So the first question was, what is the purpose of introducing ADCOM to new curriculum? So 80% said that it is the purpose is to improve their communication skills, to have better relation with the patients. But 20% said it is just something new to the new curriculum. Since the new curriculum has started, so something new must have.
Excuse me, ma'am. Sorry to interrupt. You have only 1 minute to wind up.
Yeah, sure. So and they were asked do you feel that teaching modules in phase 1 is are good enough? So 60% said yes, but 20% said this is there are repetitions of the topics, especially the communication part is being repeated in the modules. And do you feel that hours dedicated is good enough? They are saying the answer was it should be reduced. It's quite. The number of hours dedicated to ADCOM is slightly more, and that should be reduced because of COVID time. They are getting less time to study, so that is ADCOM module is consuming more time. So this is what, and so any suggestions? So they say it's strict law to prevent violence against doctor. That's 40%. They said improving infrastructure will also facilitate, will decrease the violence against the doctors. And some 60% students reported that improving doctor-patient relationship along with the improved infrastructure will facilitate will decrease the violence against the doctors. And these were their suggestions. So that concluding the study, embedding ADCOM across all years of training to new medical curriculum, it's a welcome change. Early exposure to communication skill and ethical practices will surely improve medical students and will be helpful in improving doctor-patient relationships. There are repetitions of topics that can be curtailed or reduced, considering the fact that due to COVID, admissions are delayed, resulting in a reduced time for phase 1 studies. Improving infrastructure and laws to prevent violence against doctors will surely reduce their apprehensions. These were the references. Thank you.
Thank you, ma'am. So, questions? Ma'am, can you hear us?
Yes. Can you?
Yeah. You said the knowledge, attitude, and practice.
Knowledge, attitude, and communication skills.
Communication skills. Okay. So the means communication skill through demonstration. It was assessed by whom?
So it was assessed by the tutors, by the faculty.
And
initially, they were given lectures regarding how to communicate, how to deal with their patients, what are the parameters of good communication, parameters of bad communication. And after that, they were given simulated patients, case studies, and real patients also in the clinical setting. They were taken for the ward round clinical settings. They were shown
Okay,
how.
and psychomotor skills were demonstrated, you said. So, what was the method of assessment of psychomotor skill? Most
Sir,
of the students were actually satisfactory response.
Sir, there are 5 competencies. There are 5 modules. So all those 5 modules were related to these 5 competencies. For example, for cadaver, whether they are respecting to cadaver or not.
That you said, but what was the criteria to say that it was satisfactory?
Sir, like there are criteria. Suppose if the person is, if the student is being assessed for the communication skills. So how he is talking to the patient, what is his, how he is approaching the patient, whether he is able to open the conversation. And if he is opening the conversation, what is the confidence level of the patient, of the student, and whether he is able to win the confidence of the patient or not, whether he is able to explain the condition or the clinical condition to the patient and the related patient party or not, whether he is able to convince the patient party about the clinical condition and the outcome, prognosis and diagnosis or not. In simulated ones, obviously, because they are first year students. But some conditions like fever and all that can be done in the real patients also.
This is an exhaustive questionnaire that were given to the student. We feel when you presented, they were like taken on different sessions, or it was the data was collected in one session.
No, sir, it was in different sessions, but the questionnaire was given to the patients, but the competency evaluation was in different sessions.
Okay, and the data was collected in which way? That was soft way, or it was collected with the hard copy?
Questionnaire was distributed to them, and then they filled up that form and submitted to us. So whatever
Was
their
it
physicians.
anonymized, or they have to write their roll number and names on it?
No, sir, not roll number, name, nothing was required. Just the form, and they're supposed to fill up that form. So that we distributed 150 forms, but we got back 140 forms for us. Completed
Okay, so
140
it was
forms.
anonymized. That means it was anonymized.
Sir, there was no revelation of the name and like who is, and that was not the thing. Only the number was counted. How many are reporting what is their response?
And were the questionnaires validated before?
Sir, it was a kind of pilot study to validate the questions. There are other ways to do the like Kalamaja consensus scale is there, but we thought that will be because just it was a kind of pilot study to validate the question, so that can be done. It can be used in the further studies. Like next year, we can improve and we can do some more it's a
Okay,
kind of pilot.
thank you. Thank you. Any question from audience?
Any online question? Thank you, ma'am. Thank you so much.
Thank you. Thanks.
This concludes our free paper presentation. I would like to thank our respected judges for chairing this session. Now I call upon Dr. Shivani ma'am to felicitate our respected judges. Dr. Shivani ma'am is a professor in physiology department of ESIC Medical College. Ma'am is a reputed academician in this esteemed medical college. Now, Dr. Monica ma'am is a professor in physiology department, pharmacology in ESIC Medical College. Thank you, sir. Thank you. Thank you, ma'am. Thank you so much. Now move on to the next session, Symposium 8. Wait करना पड़ेगा. हाँ चेयरपर्सन हमारे MK सर अभिनव दीक्षित सर है। दीक्षित सर है कि नहीं? स्पीकर तो है हमारे पास। दीक्षित सर को हाँ सर योर PPT is ready sir. It's here. Okay. More than 8 years. ठीक है सर. MK से नहीं आया ना? Good afternoon, one and all. A very warm welcome to all online, offline dignitaries, distinguished chairperson, participants, faculty in this wonderful afternoon, day 2 of Epicon 2022. It is my immense pleasure to be here, and I hope that we all will have a great session here. As we all are aware, that theme of this symposium is practice of clinical cardiorespiratory physiology. The respected chairperson of this symposium is Dr. Abhinav Dikshit and Dr. MK Sen. Dr. Abhinav Dikshit is currently working as a controller of examination and professor and head of the Department of Physiology, AIIMS Jodhpur. Sir is a fellow of Royal Society of Biology, UK, International Medical Sciences Academy, and member National Academy of Medical Sciences, India. He is in charge of a cognitive neurophysiology lab at AIIMS Jodhpur and has a funding and collaborating project with various institutions. Next chairperson is Dr. MK Sen. He is also not there. Okay. The chairperson can, sir, you can introduce the speaker. Thank you so much, sir.
Good afternoon, everyone. First of all, I'd like to convey my gratitude to the organizers for inviting me to chair this session. As the title goes, Practice of Clinical Cardiorespiratory Physiology, this symposium will showcase the experience of physiologists who are directly involved in providing clinical physiology services to the clinicians in the domain of cardiorespiratory physiology. And the speakers are physiologists, and they are people who have implemented the objectives of the physiology MD program in actual practice. And I hope that through this talk, they will provide a glimpse of the physiological techniques that they employ for diagnosis and management of patients in the field of cardiorespiratory physiology. So to begin the symposium, our first speaker is Dr. Avinash Ingle. Dr. Ingle is an additional professor of physiology at AIIMS Raipur. He has 6.5 years experience as an intensivist in the ICU. He has also received the award for the best paper presentation at Singapore Prevention and Cardiac Rehabilitation Symposium by World Heart Federation. He has done various projects on yoga-based lifestyle changes, various online surveys on medical practitioners and school-going children. So I'd like to call Dr. Avinash to deliver his talk.
Thank you, Dr. Dikshit. Thank you. Newer techniques in practicing clinical cardiopulmonary physiology. Why these techniques they are important? and why physiologists should be involved in clinical, or assisting in clinicians, or directly diagnosing also certain disorders, or ruling out certain risk factors, and at all. So, what we are going to discuss is the newer modalities which are available to assess the various cardiorespiratory functions and the factors influencing them. Revise the basics of ultrasound technique particularly, and its utility in assessment of risk for cardiovascular disorders. Assessment of body fat percentage. In this, the body fat percentage, how it can be assessed with ultrasound as compared to the standard method. Then a measurement of epicardial fat thickness and its influence on exercise performance, and a role of intima media thickness in assessment of risk of CVD. The modalities, the newer modalities, those which are available and can be used in clinical physiology, those I feel the ultrasound I put first, because that is very easily available, and that can be used for later we'll discuss all those parameters. Cardiopulmonary exercise testing, then whole body plethysmography, diffusion lung capacity for carbon monoxide, and advanced respiratory lab, as our colleague will be discussing on that. So how that can be utilized. So let us discuss about the utility of ultrasound technique in clinical physiology. So usually the question comes, ultrasound, why in physiology? What is there to do in physiology? Why, and radiologist friends particularly, they will say that no, that is our field. Why you are using that? And that's why I want to focus here about the history of ultrasound. Let us know one thing, that he was the physiologist who discovered in 1794 the phenomena of echolocation in bats, and which was later used, that was the base of the ultrasound. And then Curie brothers, they were physicists who invented the piezoelectric effect and reverse piezoelectric effect, which was used for the echolocation. Also, then amplifier was invented by Lee de Forest. He was also definitely not the radiologist. He was an electrical engineer. Then Carl Dusick was the neurologist who used that first for actually for visualizing the brain, cerebrum. Then the latter half of 1950s, Inge Edler and Helmut, they were the cardiologists. Then in 60s was used by gastroenterology, the OBGY, gynecology and ops. Then in 70s, the radiology born. So before that, if suppose, why I am focusing on this, if we would have used this physiologist who has invented, if we only would have used it, that would have been our perspective only. So that's why if we don't use, then somebody else will be using that technique. So, and like that, most of the techniques who are used by the, who are actually invented by physiology, for example, ECG, we never said that the ECG is our this thing. It is for all. So like that, so in physiology, why it can be, it should be used, and why newer modalities they should be focused upon, because the animal experimental workload now tremendously has been reduced. You know the reasons. In my opinion, the medical physiologists, they are the doctors, but very least used, particularly in our country. And we should know this, that biochemistry, it was actually a daughter of physiology, but later now they have came across along with this newer technical evolution. So clinical biochemistry now it has become. Anatomy is also using the CT scan, endoscopy, and at some places only. But and similarly, we can also use the ultrasound for a clinical physiology lab. So why ultrasound? We are focusing on ultrasound because it is most commonly available imaging modality everywhere in all hospitals. It is there. It is non-invasive, then relatively inexpensive. Then also the live images can be acquired. Why live is more important for us? Because physiology, is, unlike anatomy, it is a dynamic branch. So the live images, they should be they are acquired very easily, stored, transferred, and reproduced also. So relatively easy to interpret. You might be not agreeing with me, but there are multiple papers on this. Even for undergraduate students, that can be taught within few weeks. And there are multiple papers on this. Even technicians can learn this within few weeks. It has been proved. Then it is evolving technology. For example, initially it was like this, then like this, then you know the currently, and later these are available, but not in India because of the other problems of the PNDT Act and all. But you can see it can be attached to the mobile-like application, and the transducer also very small. So that is being used as a live stethoscope, and it is harmless. Even in we know that even in infants also it is safe and it is portable. Now it has become more and more portable. So indications again. So what can be for what purpose they can be used in the cardiorespiratory lab? So particularly epicardial fat thickness. What is this? This is a newer parameter. Carotid intima media thickness. This is most of us this is known. And estimation of body fat percentage, this is also quite not common with the ultrasound. So pulse wave velocity is known, and quantification and quality of blood flow by Doppler and transcranial Doppler particularly, this is being used in multiple sites in the various departments. So image formation and all, I think I should skip this because time will not permit. So image formation, that anyway, that requires little so just we should know that this is the ultrasound means it is the beyond audible range. It is more than the audible range frequency. So, and that's why it is not audible. But the main thing is it depends on the density of the medium and velocity of the of ultrasound in that medium. And if that changes, then at that border, some of those waves, they will be transmitted and few will be reflected. Okay, so depending on that, the image and these reflected these waves, they will be picked up by the transducer. So where it can be used, this actually for assessment of percentage body fat, these are actually most of the instruments which are being used. Skin fold calipers, we know this. It is easy also, but other modalities, they are really not available also most of the places, and because of their cost, and DEXA scan, CT scan, there are the rays and all. So that's why the chances of radiation and all. So that's why mostly we are using skin fold caliper as a traditional method, but drawbacks are there because inter-observer errors are many, because we know that we have to pinch and then see the measure the thickness. In thickness also, we are measuring twice the dermis and epidermis because it is a fold, okay? And actual fat might be missing also many times, and that's why the poor repeatability. And so we thought of measuring these with the subcutaneous fat with the ultrasound. So that was done previously also by one or two people. So to see the reliability of the ultrasound technique versus skin fold caliper. But that was actually compared with the DEXA scan and CT scan. But we compared that with the skin fold because in both there is subcutaneous fat. And at those same sites we repeated with the skin fold and ultrasound technique. And then with the and also we try to derive the prediction equation for assessment of percentage body fat. there is one equation which is available, but we tried the newer one. So this is the image, tricep region. So there are standard sites. I am showing only at a few places. So the sites, these are tricep. So you can see this is actually skin. So this is the posterior margin of this dermis, and exactly you can see over here. These are actually this is the pad of fat, and this is the this is the deep fascia. In between these two fascial layers, there is fat which is accumulated, and this muscle that also can be very well demarcated. And here, if we put the cursor, so you can point it out particularly. And exactly in millimeters also, we can measure the distance between two, and that can be, we can visualize and measure. And that's why we felt that it is more reliable as compared to that. We published the paper, and results were the definitely, because there we are measuring twice this dermis and epidermis. Here we are not measuring. So definitely the these parameters, they will be, thickness will be lesser, and that's why. But we tried to correlate with the sites also, which site is actually correlating with that particular percentage body fat. Percentage body fat was analyzed with the standard equation that is called as Dernay-Momersley equation. So the then again EFT, epicardial fat thickness. So this we know that so that was the subcutaneous fat, peripheral body fat, and other fat is the visceral fat. Most of the times, visceral fat means usually we think about the abdomen, and but there are certain sites where the visceral fat that gets accumulated in obesity. So, and this site is the epicardium. So, what is epicardium? Between the pericardium and myocardium. So, that can also be visualized. So, we conducted this study. So, yeah. So, what is this? Is the this is actually long axis view. So, parasternal long axis and parasternal short axis views are there, and here is the right heart border, and here actually not seen properly. Here is the pericardium. In between these two, there is this is actually pericardium, and this is the thickness, epicardial fat thickness. So, putting the beam of light from this side, this is right ventricle, and over the right ventricular border, that this thickness that can be measured over here. This is right ventricle, and here actually here it is very less. This is actually the pericardium, and this is myocardium. So, and that was short axis view. So, study design and all, no time actually. So, method was we correlated this epicardial fat thickness with the standard one, that is BMI, body fat percentage, and waist to hip ratio and all. And again, so along with this, we studied on the treadmill the VO2 max also. So VO2 max, which was in our result, that was the that was more correlated with this VO2 max. You know, VO2 max, that is actually for the exercise performance. So limiting factor for exercise, that is the cardiovascular system, we know that. And in that also, in which part of the cardiovascular system? So maybe it is the oxygen consumption by the heart, and there are papers that the epicardial fat thickness that can reduce, if the epicardial fat is more, that can reduce the oxygen, that can increase the oxygen consumption, because they are using the oxygen which is being supplied to the myocardium. So this myocardial blood supply, that is shared by the epicardial fat also, and that's why that might be the reason that VO2 max is correlating the inversely proportional to the epicardial fat thickness. One more thing I wanted to emphasize, because when this study was being put in the review committee, research review committee, so it was said by clinicians that oh, this is useless. You will not get anything like that. But Later, we presented this study in the SPCRS, that was Singapore Heart Foundation Conference, which is a branch of World Heart Foundation. And they thought that our study is more actually important for the COVID, in this COVID situation particularly. And that's why received the merit award for that. So, and this one more thing, I don't know how much time. So, time is there? 5 minutes. So, carotid intima media thickness also can be used as like the epicardial fat thickness. So, this carotid intima media thickness, so which is usually 0.6 to 0.7 millimeter in normally, but if this is more than 1 millimeter, then it is there are certain studies that the study was on the known cases of cardiovascular diseases, and they found that the chances of cardiovascular disease, they are 3 times higher if the CIMT is more than 1 millimeter. So this also we are actually conducting this study, and this was CCRYN. We received the ultrasound also from them, and that's why this is also one more study that is going on. So carotid intima media thickness, this is intima and this is media. Okay, so okay, this is, and again this same thing, same modality can also be utilized for early clinical exposure. We are actually, these are the first year students, we try to teach them so they can also learn the normal cardio, at least the normal echocardiogram. So, and they were very much interested and conducted that study also, and that was very fruitful. So in conclusion, in this era, the continuously evolving modern technology, so many newer modalities are being available. Many will be coming also in future. And being a physiologist, physiology, a dynamic branch, so we should be taking interest in that, whether that can be used for physiology. So, and like that, we can use if, and there are many papers where physiologists are also working on this, particularly in this the intima media thickness, body fat percentage, and and the epicardial fat thickness. Many more studies are possible, and they are going on. Thank you. Thanks a lot.
Thank you, Dr. Ingle, for a wonderful presentation. Yes, physiologists across the world are definitely using ultrasound, but it's because of people like you that it is now come in our country. That's really commendable. If there is any questions, else we'll move on to the next speaker. Thank you, Dr. Ingle. Our next speaker is Dr. Ekta Khandelwal. She is an additional professor in AIIMS Raipur. She specializes in neurophysiology. She has used for the first time in India rheoencephalography based on impedance plethysmography to assess non-invisibly cerebral blood flow both in healthy subjects and patients of orthostatic hypotension. Her most recent work is in interventional neurophysiology in various diseases, and she would be delivering her talk online. I welcome you, Dr. Ekta.
Thank you so much, Dr. Abhinav. First of, am I audible?
Yes, you are audible.
Yeah.
You are audible. Please go ahead.
Thank you so much, Dr. Abhinav. First of all, I would like to extend my thanks to the organizer and my symposia team members. Can I share my screen, sir? Shall I share my screen?
Please go ahead.
Is my screen visible?
Yes.
Okay. Thank you so much, sir. So the second lecture for this symposia, that is practice of clinical cardiorespiratory physiology, is, which I'm going to deliver, is vascular function in health and disease, techniques and interpretation. The first thing which we all know, that cardiovascular physiology is something which is very important in both physiological perspective as well as in clinical practice. And clinicians are very much interested to understand the cardiovascular physiology so that they can interpret pathology better. It has two components. Cardiac component, that is the mainstay of clinical practice because its obvious importance, as previous talk has already told about the epicardial thickness and its importance. And it is basically the assessment of structure and functions. The another component, which is specifically assessed for us in a specific clinical context, that is vascular functions, in which again it has two two ways. There's assessment of structure and assessment of function. Assessment of structure is again by ultrasound, which is being taken up by Dr. English. So I have not touched that. So what I'm going to deal today is about the assessment of functional aspect of vascular component of cardiovascular system used in clinical practice. So as we all know that the control of cardiovascular system is a quite complex one, and it has a modulation. It has centers from the brain is modulated by higher center, which depend upon the efferent signal from the physiological state of body as well as feed forward signal. And the final end result is our heart rate and blood vessels via sympathetic and parasympathetic nervous system. So it is the autonomic nervous system which is basically responsible for control of all the modalities of cardiovascular system. The question arises why we need to characterize or quantify cardiovascular system is a physiological point of view. As a physiologist, why it is necessary for me to do these things? Why clinician can't only just take a blood pressure or a heart rate, can do the thing? The answer lies here. First of all, to quantify, actually what is the normal value, only a physiologist can say that what is the normal heart rate, blood pressure, pulse wave velocity and augmentation index, which is now a newer modality. Time serial quantification, which allows detection of inherent patterns of signal that signify normal behavior of the system. Basically, heart rate variability, blood pressure variability, and velocity is very important. Third is quantification allows to detect relationship. How we can say, okay, baroreflex sensitivity is disturbed, compliance is not good, pressure volume relationship is not there. There is a change in peripheral resistance, which was my theme of my intramural project, which I'm going to discuss in later slides. And finally, to quantify reactivity, how a physiologically healthy body and a disease body responds is basically to quantify the reactivity to further challenges. So as we all know that autonomic nervous system is the ultimate survival machine, and cardiovascular respiratory control is basically via this machine. Apart from it, all the function is controlled by autonomic nervous system to maintain the homeostasis of the body. So assessment of this autonomic nervous system is very important. As we all know that there is a classical Ewing's battery of tests, which is now being done, I think, almost all medical colleges of India. And this is the first test being used in a clinical physiology, thanks to Dr. K.K. Deepak and Dr. Ashok Jaryal, because AFT is being now carried by almost all colleges. But now the time, due to you can say recent advances in technology, we have to now step up in vascular function to increase the diagnostic as well as prognostic view. So this kind of test like blood pressure during and after exercise, carotid sinus massage, blood pressure variability, baroreflex sensitivity, blood flow to the organs, pulse wave velocity, etc., are the things. So I am not covering this big classical AFT things. I am now just discussing few techniques which is basically responsible for assessing vascular functions. For assessment of vascular function, we have to actually target two things. Either we can assess wall functions or we can assess endothelium functions. Wall function is basically give you the idea about arterial stiffness or a compliance of the artery, which is basically assessed by pulse wave velocity and augmentation index. Where we come reactivity, when you give certain kind of challenges to your vascular system, which is basically assessed by flow mediated dilatation and waveform analysis of PPG. So the derived parameters which is being used for a technique is the flow mediated dilatation, that is changes in the diameter of vessel, is basically done by ultrasound as well as photoplethysmography. This IIS as well as photoplethysmography. Pulse wave velocity is done by either using tonometer along with ECG, and again photoplethysmography can be used to assess pulse wave velocity also. Pulse wave form analysis, again this kind of, so if you see there is a common technique that photoplethysmography and arterial tonometry are the two basic techniques which can be actually used to do several vascular function. Augmentation index and blood pressure variability. I will not go in detail of each and every technique, but simplest because of the time constraint, I'm going to touch few important techniques used for assessment of vascular function in patients. First technique coming is photoplethysmography. This is a low-cost optical device, and it is a simplest device to use. But the thing is this, it basically measures the changes in the blood flow, right? In the blood flow, not basically capillary blood flow, the change in the capillary blood flow. So this is a setup. This is only a small probe, which is a PPG amplifier, photoplethysmographic amplifier, along with ECG electrode. We recorded an ADI instrument and do offline analysis. This kind of recordings we used to come. We can see this kind of recording. In the first graph, it is the ECG signal, and in the second is the PPG signal. And each signal is being marked because it is beat to beat recording. It is not like that the one we just take an average value. No, it is beat to beat calculation. So it is very accurate when used to do this kind of calculation. And while taking this, we used to take we extracted some feature, that is PP interval, pulse to pulse interval, amplitude, and pulse transit time. It is being done in this way. This is just a superimposed image of ECG and pulse waveform. Here, this is the pulse PPP, that is pulse to pulse interval, 2 pulse interval, then amplitude of the pulse wave, slope, crest time, time to rise peak, time to decay, because this all the things parameter depends upon the vasculature, functional status of a vasculature. अगर आपका vasculature stiff है तो ये parameters alter होते हैं, अगर आपका vasculature dilated है तब भी ये parameter alter होते हैं in different kind of diseases. So the various PPG measures and PTT derived from simultaneously recording this ECG and PPG signal. So this is just a part of the result of my intramural project, which I have done in the sickle cell anemia patients. What we have done, we have taken a sickle cell anemia patient, which is 18 to 35 years of age, without any further kind of any morbidity, no hypertension, no diabetes, no further disease, only homozygous sickle cell anemia patient from our sickle cell clinic. There, even if you see that the baseline recording of this patient is so much compromised, there is a significant difference between the patients and the control group. After hydroxyurea, there was no revolutionary or no any added drug is being used for this kind of patient. Chhattisgarh being lies in the sickling bed is a very challenging condition because we get a patient in a very strong sickle cell crisis, basically very strong ischemic condition. So the idea was this, is any kind of a vasodilator or any kind of things can be introduced to them, but how we can introduce it if we don't even know that what is the vascular structure. So with this idea, this study is being planned and the result is in front of you. So to assess this kind of things, we use some kind of physiological modulator. That was a baseline study without any kind of modulation. But when you do a cold pressure test, which is basically a cold stimulus, which we know leads to increase in sympathetic outflow, peripheral vasoconstriction, and increase in diastolic blood pressure, is a known response. That is AFP. If we include or club this with our photoplethysmography, we got a very good result. And the example is this. This is another patient data recording, which we have done in a diabetic patients, newly diagnosed diabetic patients, young patients of diabetes under the age of 50 years, not more than 50 years. If you just see their response, this is their baseline PPG, almost comparable. There is no difference. But after CPT, you see their recovery response and the recovery response in control. So we can say that there is some kind of vascular problem has begun and can lead to further any kind of morbidity or complication to the end organ system. So this is another data. Apart from it, another physiological modulator of vasculature is reactive hyperemia. And we all know that reactive hyperemia is now being used, clinician, especially endocrinologists, to assess many kind of disease like Cushing syndrome and diabetes, hypertension, any kind thyroid disorder. This is the technique which they really want to read because this will give you exact idea what is happening to your vasculature. In this, we used to create ischemia. This ischemia is basically created by raising the suprasystolic blood pressure. That is 220 millimeter of mercury for 5 minutes. This response leads to accumulation of hypoxia, created hypoxia and accumulation of metabolites. These metabolites leads to vasodilatation. Now, this vasodilatation is when the ischemia, that is when we release the pressure, what we have to again read the pulse waveform and see how much is the dilatation, we are expecting and how much is the dilatation exactly happening. And this is very much altered in many diseases, especially CKD, Cushing syndrome, basically endocrinal disorders. So if we see, this is again the small part of that study. For before inducing reactive hyperemia, my idea was this: I should be knowing that what is the baseline nitric oxide level, because nitric oxide we not enos is the main vasodilator. So I really want to know. So what I have done, I have taken a sample of a patient and as well as controls, and studied endothelium 1, nitric oxide, and vascular endothelial growth factor. These are the 3 biochemical markers I have taken. And if you can see that in patients, it is endothelium 1 and vascular endothelial growth factor is significantly higher as comparison to controls, which states a vasoconstrictive state. So they have default because of sickle cell disease, they have a damage of endothelium, and their nitric oxide is reduced than control. And when we have seen the reactive hyperemia, just to explain you, this is not a complete data because this is beyond the scope of this talk. So if you see changes in pulse transit time after reactive hyperemia in patient, you see it's a significant different from control. So suppose if this kind of things we have started in our department and we started screening this kind of patient, okay, this patient is more from sickle cell crisis, so we can start some kind of medication that will be very much helpful for our clinical colleagues. So with this idea, this study is linked. Apart from it, if we come to the correlation, reactive hyperemia is a dilatation response and cold pressure test is a constrictive response. So this can be used in the same set of patients, same set of subjects to assess different kind of changes. That is amplitude, slow, pulse transit time. With this, another thing assessment is wall stiffness, wall function, that is arterial stiffness. And this is a most famous diagram of our Guyton, which shows our normal compliance of the artery and dropping of the pressure. But what we see whenever there is arterial stiffness, what will happen? There is continuous pulsation in the capillaries and loss of dampening of pressure wave happens. This is very much common in the patients with chronic renal disease. Lots of studies has been done, and what we have found that a stiffer arteries.
I would request you to please wind up your presentation. We are running short of time actually.
Sir. This is like, I'll be quickly doing. Okay, sir. Stiffer arteries have higher pulse velocity, leading augmentation and pressure at iota. So we know that there is definitely problem. This is the way we used to assess pulse wave velocity by using sphygmocore, and mainly 2 arteries were taken, carotid and femoral. And by taking their distance and time travel, we calculate pulse wave velocity. So stiffer artery, there is increase in pulse wave velocity, increased augmentation, increased systolic blood pressure, decreased baroreflex sensitivity, heart rate, and increase in blood pressure variability. The last and the important thing is the cerebral blood flow, which I have done in my thesis, and as sir told, by using rheoencephalography. But this is what I'm talking about, transcranial Doppler, which is very much used for assess blood flow, which we have standardized. Transcranial Doppler is again ultrasound-based technique and non-invasively, and which target the vessels of your circle of Willis. And if it is basically done by using 3 windows: transtemporal window, then we have transorbital window, and then we have transforaminal window. So this 3 windows targeted 3 different, all the arteries of the circle of Willis. So when this is just a schematic representation how it do. When we keep the probe in a transcranial window, somewhere here 2 Hertz probe, and we move, we can actually target whatever the artery we found. And to understand what kind of artery is this, we have a certain kind of parameters for it. By vessel identification criteria, what window we have used, how we have used transducer position, what depth we have used, flow direction, spatial relationship, along with mean velocity. So this is a standard thing. I'll just take one example: middle cerebral artery. The window probe is transtemporal. Depth is, that is the setting of a transcranial Doppler machine, is in 30 to 60 millimeters, and the direction is towards the probe, and it is that is in red color, and the approximate velocity for a normal healthy individual is 55. So this is just a spectral delay display where we target mean velocity. And when you use just to see the response, inhalation of 6% carbon dioxide, like to see in hypoxic conditions, especially kind of COVID kind of a patient, breath holding, even you see a 30-second breath holding increases the velocity significantly, drastically. Just hold a breath for 30 seconds and your middle cerebral artery responds this much to hypoxic condition. And this is a rebreathing exercise when we used to rebreathe carbon dioxide. This is day 1 minute data, and this is 3 minute data. Well, you can make it out with the amplitude this much increase. So with this, this is just a recording. Same thing when we have club blood pressure with cerebral blood flow, this kind of end of rebreathing, we can found that this much is the waveform changed. So I just want to conclude, autonomic and vascular function testing will continue to guide and aid the clinical practitioner in many other fields. And with this recent advances, we can actually bridge the gap between the basic and applied sciences. Thank you very much for your patient hearing. Once again, I want to thank you.
Thank you, Dr. Ekta, for a wonderful lecture regarding various techniques that the physiologists can use for assessing the vascular functions. Due to positive time and because of the fact that we are running the session late, we'll go on to our next speaker.
Yes.
And our next speaker is Dr. Vishal Bansal, who is a clinician scientist heading the Department of Physiology at VP Chest Institute, Delhi. He has established the state-of-the-art cardiopulmonary rehabilitation clinic at VP Chest Institute for management of patients with chronic respiratory diseases and post-COVID respiratory complications. He is currently working on research in hypoxia on healthy individuals and respiratory patients. He has also developed disease models of diabetes, hyperreactive airways, and coronary artery disease in lab animals for better understanding of chronic disease mechanisms and potential therapeutic approaches for controlling them. I hand over the mic to Dr. Vishal for his talk.
Thank you, Dr. Dikshit. Good afternoon, good evening, everyone. There's very less audience. I don't know how to go about it, but slide me, Ali. Okay. And I thank the organizer also for inviting me. And this is a very important topic as a physiologist because somehow there is always a point in our heart that as a physiologist we are not able to do much for the patients. So I guess this symposium organized that we can have a bridge between the clinicians and applied physiology. So under that series, I'll be talking about the role of exercise training in management of chronic respiratory disease. How many of you think there is a question that if a patient has 15 to 20% of lung function left, can you prescribe him exercise? That he says that I'm unable to wear clothes, I'm too breathless to walk few steps, I can't take bath. So do you, it's not good? Okay. Yeah, so how many of you say yes, you can prescribe him exercise? So here madam says that you cannot prescribe, it's not good for patient's health. Well, after the lecture, maybe you will change your views. So I'll be taking this topic under these headings. What's happening? I'll be covering this topic under the introduction and pathophysiology of why there is exercise limitation in chronic respiratory patients. What are the benefits of exercise training? How do we assess the patients before putting them into the exercise program? Then how do we do the exercise in these patients? And if required the oxygen supplementation, then what has been our experience? And what is the take-home message? Now, chronic respiratory disease, there are diverse of pulmonary disorders like COPD, asthma, interstitial lung disease. We are full with tuberculosis, then there is lung cancer, and recently we had COVID, and then we have long COVID. So all of these involves lung airways and parenchyma by inflammation, cavitation, and fibrosis, which leads to reduced compliance and increased elastic recoil. There are ventilation perfusion derangements. There is a diffusion impairment, as you just heard Dr. Ingle about doing the diffusion capacity for the carbon monoxide. So persons who have 15 to 20% lung function left, they have severely deranged diffusion capacity. Then there is neuromechanical dissociation, circulatory and cardiovascular limitations. There is malnutrition due to cachexia of chronic disease. There are skeletal and ventilatory muscle weaknesses. So these respiratory patients, they undergo a downward spiral that they have a respiratory impairment. There is a dyspnea during exertion. So they abstain from exercise. And this abstention leads to physical deconditioning, and they become so deconditioned that there happens a dyspnea during activities of daily living. So normally these patients, they present to you with productive or non-productive cough, They can have exertional dyspnea, they can be fatigue, exercise intolerance is there. There is disability in activities of daily living. There is peripheral muscle weakness. There is anxiety and depression. This all leads to poor quality of life and increased healthcare visits and utilization and out of pocket expenses. Now, what are the factors which contribute to this exercise intolerant respiratory patient is cardiopulmonary dysfunction, ventilatory impairment, skeletal and peripheral muscle dysfunction, and there are other miscellaneous factors. I'll quickly go through one by one. In cardiopulmonary dysfunction, there is pulmonary vascular damage and remodeling, as you just heard about Dr. Ingle and Ekta, that you can do the vascular assessment. There is restricted flow through pulmonary artery circulation, loss of pulmonary artery compliance, increased pulmonary vascular resistance and pulmonary artery pressures, increased right ventricular afterload, right heart dysfunction. Then there is leftward shift of ventricular septum, which compromises left ventricular filling, diminished cardiac output, then chronotropic impairment and delayed heart rate recovery. So there is autonomic imbalance and increased sympathetic outflow. Ventilatory impairment include reduced and inefficient lung gas exchange, VQ mismatch, increased dead space ventilation, increased ventilatory demand and minute ventilation, reduced diffusion lung capacity, decreased oxygen saturation, and then there is impact on ventilatory gas exchange, in which there is an increase in ventilatory equivalent ratio for carbon dioxide, decreased partial pressure of end tidal CO2, and decreased VO2, that is peak and ventilatory threshold. And the miscellaneous mechanism include impairment of respiratory muscle function and strength. There is endothelial dysfunction, which now we just heard with Dr. Ekta that how you can assess that endothelial dysfunction. Then there is neurohormonal changes, increased cytokine levels and inflammatory response. All these chronic respiratory disease are in fact systemic inflammatory disease. They all have high levels of inflammatory markers in their body. Then there are nutritional deficiencies. Now if we talk about the pathophysiology of skeletal muscle dysfunction, it's not working. So during chronic respiratory disease, there is systemic inflammation. Pointer. There is systemic inflammation, then there are recurrent infections, there is hypoxia, hypercapnia, acidosis, oxidative stress, and decreased anabolic hormones, which leads to impaired metabolism. This leads to myopathy. Then, because we have to treat them also pharmacologically, medications are given. The steroid is a mainstay in the COPD, in asthma, in ILD. You know, they are given steroids, but steroids are a double-edged sword. They kill your muscles, they save your lungs, but they kill your muscles. There are bronchodilators also, like you must have heard salbutamol, ipratropium and all that. They all, and antibiotics, because recurrent infections warrant giving recurrent antibiotics. They all lead to, again, myopathy. Then smokers who develop COPD later on, that also leads to myopathy. And because they have all these problems, they become chronic inactivity, so psychosocial isolation is there. So that leads to muscle disuse, and all this culminates into the peripheral muscle dysfunction. So how do you see how there is a skeletal muscle dysfunction is that there is a muscle impairment. This is a typical photograph of a COPD patient in which you can see the leg muscles, so much wasting of the leg muscles. There is decrease in muscle mass, decreased aerobic enzyme activity, decreased number and density of mitochondria. The muscle capillarization also decreases, which leads to reduced oxygen utilization, the oxygen extraction utilization as the muscle. You all have learned about that muscle contraction coupling, but energy is required over there. There is a fiber shift. There is a fiber shift from 2A to lysosomal to glycolytic, fast glycolytic. There is poor oxidative capacity, and muscle dysfunction is manifested as a decrease in muscle strength, decreased muscle endurance, and increase in muscle fatigue. This in the bar chart you can see this is a COPD patient in blue and normal control in yellow. You can see all the different group of muscles, the muscle strength is reduced. This is in kg, and it's like reduced by 20 to 30%. then the muscle endurance also is reduced, and the muscle fatigue sets in early in the chronic patients. Morphologically, if you see, the capillary density in COPD is much reduced as compared to the normals one. There is a shift in the from type 1 and in the type 2 to the type 2, and this is a normal. And if you do the CT scan of the mid-thigh section, you see the area is reduced. This is the mid-thigh section over here. The muscle content is loose, is coming. So what's the definition? So exercise training is an evidence-based non-pharmacological intervention for patients with chronic respiratory disease who, despite optimal pharmacotherapy, are symptomatic and often have decreased daily life activities. And the main aim is to restore the patients to the highest possible level of independent functioning. Who all can benefit from this exercise training? Chronic respiratory disease, all chronic respiratory disees, whether it is COPD, ILD, asthma, post-TB, pulmonary artery hypertension, patients who have received the chemotherapy for the lung cancer, and now recently in COVID-19, and then the long COVID manifestation which we are seeing now. So despite optimal pharmacological treatment, they are suffering from significant dyspnea on exertion or at rest. They have difficulty performing activities of daily living or have a decreased exercise tolerance. Patients who cannot be get benefit is patients you cannot include in the program are the musculoskeletal or neurological disorders, who have recently having infection, or who have unstable cardiovascular disease. Now, benefits of exercise training are decrease in breathlessness and fatigue, increase functional exercise capacity, improve oxidative capacity of muscle, enhance neuromuscular coordination, improvement in quality of life, improvement in anxiety and depression, and decrease healthcare utilization. So these are the evidences over here in which we can see the patients who are enrolled in the exercise program, the functional exercise capacity increased, and their health, that is chronic respiratory questionnaire dyspnea scale, that also was increased. There was a decrease in the breathlessness scale post exercise, EXT is post exercise training, both at the same load. Before training, they were severe breathlessness, and leg discomfort was also severe, but after exercise training, their both parameters have improved. Morphologically, there has been an increase in oxidative enzyme, that is citrate synthase, and HADH in the muscle, which has been proven with the biopsy after the exercise program. And if you look at the respiratory parameters during the maximal exercise test, post-training, the VE, that is the ventilation per minute, reduced from 34.5 to 32. The lactate also was reduced at the same workload, same iso time, same workload. And before exercise training, the lactate was 3.36, but after exercise training, they were 2.82. And the lactate threshold, LT is lactate threshold, that also increased. So this overall shows that the patient after exercise training improves in their respiratory and metabolic parameters. It was also seen, one study was done in the Europe when they found that patients who declined exercise program, there were 60% of them died, whereas those who enrolled themselves in the exercise program, even after 48 months, they were still surviving. So this all shows that participation in the rehab program or exercise training program and degree of comorbidity were the only factors participating in the prediction of mortality. Now coming to how do we do it? Before putting into the program, we do their assessment, that is pre-induction assessment, in which we assess their medical history, comorbidities, medication review is done. Then we assess all these parameters, that is how much breathless they are, what is their nutritional status, how much disabled they are, what is their oxygen status, how much capacity they have, what's their quality of life, and how are they anxious and depressed, and what are their goals. Breathlessness is assessed by Borg scale or a modified MMRC scale, Medical Research Council scale. Nutritional status can be simply done by BMI or the blood levels. Then we have body composition by bioimpedance. You heard Dr. English saying about the fat-free mass and all that, and bone mineral density. You all have this classical photo of pink puffers and the blue bloaters in emphysema and chronic bronchitis. Main point you have to understand is the main cause of weight loss in COPD is the reduction in the skeletal muscle mass rather than the loss of fat mass. So the fat stays, but the muscle goes. So in COPD, based on the BMI and reduction in the fat-free mass, which is assessed by a bioimpedance, fat-free mass index, nutritional abnormalities in COPD have been categorized into 4 types. When they have a normal or above normal BMI, so normal fat-free mass index, then everything is normal. If they are low fat-free mass index, there is a muscle atrophy. But if they have low BMI, then there is semi-starvation, and low FFI with low BMI, then that is cachexia. So activity of daily living also can be assessed by doing the oximetry and the home environment. I'll just quickly go through this. And oxygen status is very much important. Now you have to see that respiratory patient can be breathless at work, during activity, or at rest. But what is their oxygen status, that needs to be elucidated, because patient can be having a normal saturation with breathlessness, patient can have a low saturation with no breathlessness, or maybe both. So breathlessness and desaturation, they don't go hand in hand. You nearly have to evaluate for that. So basic is we do 3 types of assessment at the rest, that whether patient is desaturating at rest, and if he is during activity he is recording, then we record distance and time to desaturation. And always remember one thing, that patients who desaturate during walking, when they are sleeping, they will be desaturating. So in the morning, when you heard about the sleep studies and all that by Tripat, sleep study also comes part of this rehab program, which we are talking about here, that overnight how the patient behaves. So there is a corollary, the patient who desaturate during 6-minute walk test, that is one of the way to assess the patient's function capacity, they are more likely to have a nocturnal hypoxemia. So always remember that nighttime patient should be put on the oxygen if they are desaturating during walking. This is how we record their oxygen saturation. We walk along the patient and note time to desaturation, distance to desaturation. These are the various ways which can assess the functional exercise capacity. Most common is a 6-minute walk test, and the gold standard is cardiopulmonary exercise testing. And then health and quality of life, we have many questionnaires. Most commonly used is Sanjaw respiratory questionnaire, because it is freely available and it's available in 16 languages, including Hindi and all the Indian languages. Then anxiety and depression also said they are all standard questionnaires. Some are licensed and some are free. Now coming to the exercise training. The basic mantra is treat the muscles to treat the lungs. See, what happens is patient has come to you when he has reached a stage when his lung improvement is irreversible. The damage is irreversible. You cannot reverse the damage. But still, by reconditioning the muscles, you can improve his quality of life, his functional capacity. So there is a FIT principle for doing the exercise prescription, that frequency, intensity, type and time. So you can have any kind of exercise, walking, simple walking, cycling, arm exercise, stair climbing, inspiratory muscle training. Intensity can be about the load, how much load is given on the cycle or treadmill, what's the speed, how much elevation in the treadmill is given, the duration, frequency, twice a week, thrice a week, interval or continuous. Now initially when we start with our patient, they are so disabled, they are unable to pedal the cycle for a continuous 2 minutes also. So we have to give them interval training, that 2 minutes, and give them breaks so that they catch up their breath. And if they are desaturating, we put them on oxygen and then we ask them to pedal or do the exercise. And we gradually progress them as per the symptom. Normally we make them work around 3 to 4 dyspnea scale. That is what we have, which we set the limit, that at that level we train them to the cycling or walking. So we start with the breathing retraining, and this can be enhanced with the yoga pranayama also, or simple exercise training, which includes pursely breathing, diaphragmatic breathing and other exercises. Now these are the various modalities which we do in our rehab clinic. This is the arm ergometer over here. I don't know whether you can see this patient is on oxygen catheter also, because she had very poor lung capacity. This lady is doing the weights training, and you can see she is connected to the oxygen cylinder. This patient is also on oxygen. This cylinder is over here. He is doing the cross trainer, sitting cross trainer, and this is the cycle ergometer. These are the stair practices. Again, this lady is an ILD patient, and we had trained her, and she was from Uttarakhand. She said she has to go uphill and downhill day-to-day activity, but she was desaturating. So we put her on the full program, and then she was able to do a better work. This is inspiratory muscle training, and this is a treadmill walking. Now, why do we do oxygen supplementation? Because it decreases dyspnea, leg fatigue, and dynamic hyperinflation and ventilation, per minute ventilation also reduced. And it improves health-related quality of life, 6-minute walk parameters, training intensity. So with oxygen, you can train the patient at a higher workload, and the cerebral oxygenation also improves. Now there was a Cochrane review that it said that the oxygen in a non-hypoxemia, mildly payable COPD, who would not otherwise qualify for home oxygen therapy, you can still give them, but it should only be done for the exercise training, not for the long term. Now this program is for, if we admit the patient, it's for 6 to 7 weeks in 5 times a week. If the patient comes as an outpatient, then it is 12 to 14 weeks, 3 times a week, or 15 to 17 weeks, 2 times in a week. When we discharge, we tell them to continue with the home program, whatever is available to them, and we evaluate at discharge what is the outcome, and before he started and after we are discharging, whether there is improvement in his functional capacity or oxygen status. Our experience. We did one study in a COPD patient in which we had one group who was control group, which only put on the normal medication, and one was the exercise train group, in which was with medication and exercise training. And you can see the predicted FEV1 of 57%, and they were in the moderate to severe group. And their resting saturation was 95%, so that was within the normal range. And we did their mid-thigh CT scan, and we found that the exercise train group has significant increase in the muscle mass, and their functional capacity as assessed by the 6-minute walk test was also significantly improved as compared to the one who did not participate in the exercise program. Now I will just like to show you a patient experience. She is a patient, 39-year-old lady with tuberculosis, and she had disability and activity of daily living due to shortness of breath. She had exertional desaturation, reduced functional capacity, and nutritional deficiency. If you see the CT scan, because of the tuberculosis, total cavitated. So her right lung is more or less gone, and this is all fibrotic. You can see this is a cavitation over here. Her lung function were 42%, FEV1 was 46%, and ratio was 93%, and she had pulmonary artery hypertension. So please play that video. The video will be playing separately.
मेरा नाम शबाना है। 8 साल पहले मुझे टीबी हुआ था। मेरा नाम शबाना है। 8 साल पहले मुझे टीबी हुआ था। उसका इलाज मैंने LNJP से कराया। फिर पूरा इलाज करा लिया। उसके थोड़े दिनों बाद से मुझे सांस फूलने की प्रॉब्लम होने लगी। फिर LNJP में दिखाते रहे। फिर कई जगह बाहर प्राइवेट भी चेक कराया। सांस की दिक्कत ज़्यादा आगे बढ़ती रही। खांसी होने लगी बहुत ज़्यादा। चलते टाइम भी बहुत खांसी होती है। सांस भी फूलता है। LNJP में बार दिखाते रहे। पीली कोठी भी दिखाया, गुलाबी बाग हॉस्पिटल में भी दिखाया, सब नेगेटिव आती है। इसके थोड़े फिर पूरा इलाज करा लिया। उसके थोड़े दिनों बाद से मुझे सांस फूलने की प्रॉब्लम से कराया। फिर कई जगह उसके थोड़े खाते रहे। फिर कई जगह बाहर प्राइवेट में चेक कराया। सांस की दिक्कत ज़्यादा आगे बढ़ती है। खांसी होने लगी बहुत ज़्यादा। चलते टाइम भी बहुत खांसी होती है। सांस भी फूलता है। LNJP में बार दिखाते हैं। पीली कोठी भी दिखाया, गुलाबी बाग नेगेटिव आती थी। हॉस्पिटल में भी दिखाया, सब नेगेटिव आती थी रिपोर्ट। ज़्यादा बीमारी बढ़ती रही। ऐसी आगे ज़्यादा बीमारी बढ़ती रही। सांस बहुत फूलने लगा। नेक्स्ट ईयर जो बहुत ज़्यादा तबीयत खराब हुई। LNJP गए, वहाँ पे CT स्कैन वगैरह हुआ तो उन्होंने कहा एक लंग्स तो बिल्कुल डैमेज हो चुका है, दूसरे में भी इन्फेक्शन है। फिर उन्होंने पंत हॉस्पिटल में रेफर कर दिया। पंत हॉस्पिटल में गए तो उन्होंने बस ECG करके LNJP वापस भेज दिया और पटेल टेस्ट भी आने की। फिर 4-5 महीने प्राइवेट से इलाज कराया। फिर उसके बाद पटेल टेस्ट में आया। यहाँ पे आके OPD दिखाया तो काफ़ी फर्क पड़ा था। OPD में 3-4 महीने दिखाया। फिर उन्होंने एक्सरसाइज के प्रोग्राम के लिए फिर 2 नवंबर से एक्सरसाइज के लिए आ रहे हैं। फिर 2 नवंबर से एक्सरसाइज के लिए आ रहे हैं। पहले चल भी बहुत ज़्यादा फायदा नहीं कर पाती थी। पहले चल भी नहीं पाती, कुछ काम भी नहीं कर पाती थी। अब सब काम कर रहे हैं, चल भी रहे हैं। पहले पूरी ठंड में बस बिस्तर पे लेटे रहते थे, कुछ नहीं करना, बाहर निकला ही नहीं जाता था, उठा भी नहीं जाता था। अब जो है सब काम अच्छी तरह से कर लेती हूँ। चल भी लेते हो, सांस भी बहुत कम हो रहा है।
कल ही हुआ है।
एक छोटा बेटा है 5 साल का, कल ही हुआ है।
5 साल से
5
उसका
साल
बर्थडे
10
कभी नहीं
जनवरी,
मनाया, कल पहली बार मनाया।
5 साल से उसका बर्थडे
क्योंकि
कभी
हर
नहीं
साल
मनाया,
यही
कल
होता था,
पहली बार
बहुत ज़्यादा
मनाया।
तबीयत खराब रहती थी।
क्योंकि हर साल
बस
यही होता था,
हॉस्पिटल या
बहुत
बिस्तर
ज़्यादा
पे
तबीयत
घर
खराब
पे
रहती
भी
थी।
ऐसे
बस
उठा भी नहीं
हॉस्पिटल
जाता
या
था, कभी भी
बिस्तर
नहीं
पे
बनाया।
घर पे भी
इस
ऐसे
बार
उठा भी
पहली
नहीं
बार
जाता
ऐसा
था,
हुआ
कभी भी नहीं बनाया।
और ये
इस बार
पहली
पहली
ठंड है
बार
जो
ऐसा हुआ है।
बाहर भी आई
और
हूँ
ये
exercise के
पहली
लिए,
ठंड है
एक
जो
दिन छोड़ के,
बाहर भी आई
वरना
हूँ
पूरी ठंड
एक्सरसाइज
में
के लिए
बस
आ रही हूँ,
घर
एक
पे
दिन
ही
छोड़
रहते
के।
हैं, बंद रहते
वरना
हैं,
पूरी
बिल्कुल
ठंड में बस घर पे ही
बिस्तर पे
रहते हैं,
पड़े
बंद
रहते हैं।
रखते हैं, बिल्कुल बिस्तर पे
बहुत
ही
ज़्यादा
पड़े
फायदा
रहते
हुआ
हैं।
एक्सरसाइज करने से। चाहती हूँ कि
बहुत
आज
ज़्यादा फायदा
ब्रेक
हुआ
के बाद
एक्सरसाइज
फिर
करने से। चाहती हूँ कि
दोबारा
आज
मुझे इस
एक
प्रोग्राम
ब्रेक
में
के बाद
शामिल
फिर
करा
करें,
जाए।
फिर दोबारा मुझे इस प्रोग्राम में शामिल करा जाए।
घर में
हाँ,
और
पहले
अपने
कुछ
काम
काम
कर
नहीं
पा
हो
रही हैं जो
पाता था,
पहले नहीं कर पाती?
अब मैं सारा
हाँ,
काम
पहले कुछ काम नहीं हो पाता था, अब मैं सारा काम कर रही
खाना
हूँ।
बनाना, कपड़े
अपने
धोना,
सारे काम,
बर्तन
खाना
सब कर
बनाना,
लेती हूँ।
खाना
नहाना,
बनाना, कपड़े धोना,
पहले कुछ काम
बर्तन
नहीं
सब
कर
कर
पाती
लेती हूँ।
ठंड में तो
पहले
बिल्कुल ही
कुछ काम नहीं कर पाती
थी।
थी,
गर्मी
और
में
ठंड
थोड़ा
में तो
थोड़ा कर
बिल्कुल ही
लेती
कुछ
थी,
नहीं कर
ठंड में
पाती थी।
बिल्कुल कुछ नहीं करना
गर्मी में
होता।
थोड़ा थोड़ा
बस
कर लेती
बिस्तर पे
थी,
ही
ठंड
लेटे
में
रहती
बिल्कुल कुछ नहीं करना होता।
अब इस बार
बस
मैंने
बिस्तर
ठंड
पे
में
ही
काम
लेटे
भी
रहती
करा,
थी।
सब काम खाना वगैरह
अब
सब
इस बार
बना
मैंने
लिया।
ठंड में काम भी करा, सब
आना
काम
जाना
खाना
भी सब
वगैरह
कुछ
सब बना
ठीक है।
लिया। आना जाना भी सब कुछ ठीक है।
So this is how the exercise program helped, and you can see how disabled this lady was. She was not able to celebrate her child's birthday also. This is the first time after this program she was able to do it. So in the take-home message is that exercise training or a pulmonary rehab program is a new hope for these respiratory patients. It's a treatment in which there is a reduction in breathlessness, increased exercise tolerance. The patients can walk, bathe and dress themselves. There are reduction in hospital visits. They can socialize, have better quality of life, and they are more happy. So I like to end my lecture and say, when you can't breathe, nothing else matters. Thank you. So coming to the first question, have you changed your opinion now? So do you think it's good? Yeah. Any questions? Decadurabolin. Yeah, we give our patients decadurabolin to improve the muscle strength because they are anabolic steroids. We do give them to our patients also. So the basic idea of presenting this lecture over here was to tell you that as a physiologist, as an exercise physiologist, you can use exercise as a therapeutic tool to improve the patient's life. See, you have to, it can be in any field. It can be pulmonary, cardiac, like you have told about the cardiac thing. All kind of rehabilitation are there. Neuro rehab is there. Only thing is the problem is the true pulmonologist, cardiologist or a neurologist, they won't have enough time to do the rehabilitation. They usually give them to the physiotherapist, which don't have the complete knowledge about the medical condition. But we all have done medical MBBS, we are able to understand the disease, the medication part, we can review the medication, which the physiotherapist cannot do it. So physiotherapy is part of rehab, but rehab is not physiotherapy. And this is where, as a physiologist, you can pitch in and you can talk to your clinical departments, wherever you have, like in NIMHANS, you can have a neuro rehab. Like we are in a chest institute, so we are doing pulmonary rehab. If you have multi-specialty hospital, you can talk to cardiologists, medicine people. In medicine, you have all kind of variety of patients are there. So this really helps. This rehab really helps. And see, it comes to a point when after medications, patient has lost hope. Then the rehab comes in and the medication compliance also improves with that. नहीं तो पेशेंट इनहेलर लेते रहते हैं, 300-400 का इनहेलर है, वो कहता है मेरा सांस तो फिर भी फूल रहा है, तो मैं इनहेलर भी क्यों लूँ? जब इनहेलर लेने से पहले भी वैसे ही, बाद में भी वैसे ही है, they stop taking medication. But when they come to our program, then they said, no, we tell them that you take inhaler and you take breathing exercise, you do this exercise. So with that, their compliance improves and that's how they get improvement. That's all. Thank you.
Thank you, Dr. Vishal, for a wonderful presentation. And this is actually what physiology is all about, clinical physiology is all about. Thank you.
Thank you so much, sir. Thank you, Dr. Vishal. Thank you, Dr. Avinash, sir, and Dr. Ekta for their wonderful presentation, sir. Now moving toward the felicitation prayer ceremony, I would request respected chairperson, Dr. Abhinav Dikshit to kindly felicitate our speakers of this session. Dr. Avinash Ingle. Thank you, Dr. Avinash. Next is Dr. Vishal. Dr. Vishal Bansal. Thank you so much, sir. Thank you, sir. Thank you so much, sir. Thank you. Now I would request Dr. Shilpa ma'am and Dr. Namrata ma'am to kindly felicitate our chairperson, Dr. Abhinav Dikshit, of this session. Dr. Shilpa ma'am is Associate Professor in Department of Physiology, ESIC Medical College, Alwar. And Dr. Namrata ma'am is Associate Professor in Department of Physiology, ESIC, Faridabad. We are happy. Oh. It's a great reunion, I think. Thank you so much, sir. Thank you so much, ma'am. And I thank all the teachers, all the dignitaries and staff for having this successful event. And thank you so much, everyone. Thank you so much, sir. Okay. Kindly join to Dhanvantari general body meeting after this session. And now I close this event for the day. Thank you so much.